You. So good evening all, good evening everyone. Warm welcome to each one of you that as we kick off 12th series of our ISAR UNS Fertility Catalyst webinar. And no, we are conducting this webinar during our World IVF Day week. That's truly immense. It's a true pleasure that I can see more than 400 attendees, means 400 doctors. They are listening and they're seeing this our webinar. And I must welcome all esteemed IVF as well as gynecology expert across India who have gathered here on this platform. You are truly a catalyst in the field of reproductive health and making invaluable and contribution and innovative medical treatment as well as transforming life nationwide. We at UNS, we take a to being one of the fastest growing nutraceutical company, and we are committed to making significant on people's lives through our highly quality products. Our infertility portfolio, which includes CoQ 300, which is specially designed for PR and RPL cases. CoQ-LC, we have CoQ-LC and CoQ-Man specially designed for the male infertility. Now it's a truly honor. I invite our medical team, medical head, Dr. Manish Garg, as well as the coordinator, Ms. Shruti, to introduce today's chairperson, today's speakers, and to set the contents. Over to you, Dr. Manish and Dr. Ms. Shruti.
Sure. Thank you so much, Nakul sir. So good evening, everyone. My name is Shruti Patwal and I'm from the Medical Affairs team of Universal NutriScience. And on behalf of the entire team at Universal NutriScience, I would like to extend a very warm welcome to all the esteemed faculty members that we have. This is the 12th one in the series of the ISAR Fertility Catalyst series. And it's truly an honor to be conducting this 12th month as we also celebrate 12 months of engaging scientific discussions, collaborative insights, and expert insights as well. So thank you so much for being with here. And we are also deeply honored by the presence of Dr. Bhaskar Pal sir as the chief guest and Dr. Anuradha Khanna ma'am as the guest of honor. Thank you so much, ma'am and sir, for being here today. And all of this wouldn't have been obviously possible without the blessings and support of Dr. Amit Patki sir and Dr. Asha Bakshi ma'am, and also without the support and guidance of Dr. Anu ma'am and Dr. Fessy Lewis sir. So Dr. Anu ma'am is the director of Vanch Fertility and Test Tube Baby Center, Ayushman Hospital and Trauma Center, Ayushman Multi-Speciality Hospital. Thank you so much, ma'am, for your support. Dr. Fessy, sir, he is the head and HOD and professor of Department of Reproductive Medicine and Surgery at Amrita AIMS Institute of Medical Sciences, Cochin, Kerala. He has been affiliated to various different organizations and has won several awards. For the further proceedings, I would like to hand over to Dr. Anu ma'am and Dr. Fessy, sir.
Thank you. Thank you, Dr. Shruti. So lovely evening to all esteemed doctors present here. It is a pleasure to welcome you all in this 12th series of ISAR Fertility Catalyst series. Previously, we have covered various topics of infertility like PCO, endometriosis, male infertility, about AI, use of AI in IVF. And first of all, I would like to acknowledge ISAR President Dr. Amit Patki and Secretary General Dr. Asha Bakshi Madam. Actually, I must say this is the brainchild of ISAR President Dr. Amit Patki, and it is a wonderful platform to share our knowledge. And today's webinar is on genital cox and infertility. And we all know it is really difficult to diagnose the genital cox in females as there is no single diagnostic test with which we can say the patient is suffering from this disease. And here we use combination of tests to diagnose this disease, and good counseling of patients is also required. So Dr. Amit Patki and Dr. Asha Bakshi ma'am, they can't join today as they are in doing some emergency surgery. So they may join later. So it is a privilege for me to invite our chief guest, Dr. Bhaskar Pal sir. Can you display sir's CV?
That's not required.
Sir, we all know you.
Yeah, Anu, that's not required. Thank you very much.
So we need your blessings.
Thank you. At the outset, sincere thanks to ISAR and to my dear friends, Fesi Lewis and Anu Agarwal, for inviting me to be the chief guest. This is indeed an honor and a privilege. And it's an excellent program, and it's great to be among seniors, colleagues, and friends like Professor Anuradha Khanna, Professor Shulekha Pandey, Dr. Raki Singh, and Dr. Suparna Banerjee, my dear friend, Dr. Seema Pandey, Dr. Tania Bakshi. And we have an excellent program, and you got who better than Dr. JB Sharma to speak on diagnosis and management of genital cocks. JB's got huge amount of work in this field, and I think I think he's got one of the largest amount of work in tuberculosis in gynecology in India. It's also great to have Dr. Ekika Singh speaking on genital cocks and infertility, which is again a very, very big issue when we have subtle tests showing, and I'm sure that they will highlight on that, which turn out to be positive and which tests we should go by. And there are case scenarios of genital cocks in infertility, which is moderated by Dr. Sangeeta Rai. I'm sure this will be a great program, and I congratulate you for this wonderful initiative. And once again, thank you for having me.
Thank you.
Thank
Thank you, sir.
you, Dr. Bhaskar, for that, for blessings. I think we are honored to be here with your presence. I think in future also we expect your wholehearted cooperation. So with this, let me invite our guest of honor. Is none other than Professor Anuradha Khanna, Madam. I think, Madam, I think we have been running this as in the introduction, Dr. Shruti told. This is the 12th episode, and each episode we specifically deal with one topic like male infertility, PCOS, poor husband, like that, so that audience will be enlightened with the knowledge of the experts in the field, and also panel discussion of case related to that, so that it will be a doubt clearing and the experience sharing session. So we have got wonderful speakers here. So with this introductory note, I request Professor Anuradha Khanna. Madam is the ex-HOD of Obstetrics and Gynecology, BHU Varanasi, President of UP chapter of OBG from 21 to 24, founder presidents of the Society for Fetal 2021 to 20.
That is
Okay, okay. Madam doesn't need introduction, but just a formality we introduce. We need your blessing and advice, Madam.
I'm so happy to have this program with us, and I will be listening throughout the whole of the program. And I'm thankful to you and Dr. Anu Agrawal and also Dr. Amit Patki and Asha Bakshi to start the program, along with our chief guest, Dr. Bhaskar Pal, and the most renowned speaker who has got a lot of work done in genital tuberculosis. And I'm reading his especially articles in recent updates, which is coming to us, a very favorite book of us throughout whenever he's publishing, and also his own book of gynecological tuberculosis. And I'm sure we are going to have a lot of knowledge along with the chairperson's respected madam. And Ekika Singh is going to speak a very good topic of very close to that is genital tuberculosis and infertility. And Dr. Sangeeta Rai is going to moderate the case scenarios. I would like to have my few words regarding genital tuberculosis, because in practice what I see that usually people, they don't take a detailed history and especially per abdomen PSPV examination. And what I suggest that whenever there's infertility, especially the area of Uttar Pradesh, we should always think in backup of hormone tuberculosis in infertility, otherwise also in PV discharge and genital tuberculosis. And regarding investigation, Dr. JB Sharma is going to enlighten on the last. But just I would like to say that ISAR, CBC, lymphocytosis, along with ultrasound, HSG, sonography, and laparoscopy, we all are doing it. But again, we should have an eye behind our back that what will be in genital tuberculosis to investigate. And one thing also, the lesions comes later on, but the problem starts from the beginning. And so, because it is also affecting the immunology in genital tuberculosis, and there is a family who runs the more prevalence towards the genetical aspect, like in SNP, polymorphism, and tau receptors. This Ekika was asking me, Madam, what do you think about immunology? And also about the CME, cell-mediated immunity is raised in cases who are having tuberculosis, which is toxic to the alloimmune and causes infertility as well as abortions, recurrent RPLs also. And also, I'm just reading about the role of PET scan at higher centers. I've seen that people are using also for diagnosing and treating the tuberculosis. So, with this small, and I've also seen I've got a thesis done for both genital tuberculosis as such in detail many, but also association of endometriosis. In foreign countries, they mention about the Shigella infection and this endometriosis. In our country, we had a thesis done in which we have found the prevalence of genital tuberculosis along with endometriosis, which we have confirmed on laparoscopic examination. And initially, we have done TB-PCR also, but nowadays we are not getting the TB-PCR done. And I'm sure Dr. J.B. Sharma sir is going to enlighten us a lot about this disease diagnosis and treatment. Thank you so much for inviting. Thank you very much.
Thank you, ma'am, for your valuable inputs. So we'll start our first session, which is about diagnosis and management of genital COX in females by none other than renowned Professor J.B. Sharma sir. For this, I would like to invite our chairpersons, Professor Sulekha Pandey, madam.
Hello. Thank you very much.
Wait.
Ma'am is ex-professor and head of Department of Obs and Gynae IMS BHU Varanasi. She's ex-professor and head UCMS Nepal Director, Srishti Fertility Clinic. She's consultant at Apex Super Specialty Hospital, Vice President of National ISAPAP 2021-2022. She's President National ISAPAP 2025. Welcome, madam.
Thank you. Thank you very much.
Our next chairperson is Dr. Rakhi Singh. She is President of Noida Society, Governing Council Member of ICOG 2024-2025, Vice Chairperson of UP State ISAR. Just a minute. Welcome, Dr. Rakhi. And our next chairperson is Dr. Monica Singh. She is Consultant Reproductive Medicine, Bhopal Fertility and Endoscopy Center, Professor at Ellen Medical College, Bhopal. She is Managing Committee Member of ISAR, Vice President, Bhopal Obstetrics and Gynecology Society.
Thank you, Anu. Thank you, Anu. Thank you.
Welcome, Dr. Monica.
Thank you so much for involving me. Thank you, Anu.
Thank you. Dr. Saroja Kapala. She's Senior Consultant, Clinical Director at Nova IVF Fertility Center. And she has done her British Fertility Society Fellowship. And she has won Best Outgoing Student in PG, wrote a chapter on adolescent PCO and hyperandrogenism, and published a paper in BGOG. Welcome, Professor Saroja.
Thank you so much. It is a great initiative to start.
Thank you. So I request our chairpersons to invite our speaker, Professor J.B. Sharma sir.
So, can I introduce Anu?
Yeah.
Yeah, sure.
Who's going
Yeah.
to introduce me? Hello.
Hello, Madam wants to introduce Sulekha ma'am?
Yeah.
Yes, please.
Thank you very much for inviting me in this prestigious webinar conducted by members of ISAR Fertility Catalyst. Without wasting any time, I have the proud privilege to introduce Professor J.B. Sharma. He's a great teacher, great orator, and a great writer. So many books he has written. It's really marvelous. He is MD, DNB, FRCOG, PhD, FMS, FICOG, FNA, Science, FIMSA, FFM, FFP. He was the head of the Department of gynae at the moment in Yashoda Medical Institute. She was a former professor and unit head, Department of Ops and Gynae, AIMS, New Delhi. And he had several important positions and achievements. And first of all, he is a great teacher. And so, without wasting our time, we would like to request you, and he is going to speak on a very important topic, that tuberculosis in infertility. So, Dr. Sharma, please proceed with your slides. Thank you very much. Once again, thanks the ISAR Catholic Society for inviting me. Thank you very much.
So, thank you very much, respected Sulekha Madam and other respected chairpersons and respected chief guest Dr. Bhaskar Paul and sir, all of you. So I'm so delighted, Dr. Anu, as well as Dr. Fessi. So I'm delighted to be here and thanks for the nice introduction. So without wasting time, we start female genital tuberculosis diagnosis and management. Next slide, please. Yeah. So a lot has been said by Dr. Anuradha and Dr. Sulekha. So just this is the India TB report. So we can go to the next slide. We will be discussing mainly. Next slide, please. Yeah. So tuberculosis involves about 8.2 million people all over the world. That we are talking about the general pulmonary and extrapulmonary TB. Next slide, please. And it causes 1.4 million deaths. But we are dealing with female genital tuberculosis, which is a type of extrapulmonary TB. And of course, extrapulmonary TB, about 9% cases are because of genital TB. And it is an important cause of morbidity in female. It does not cause mortality like pulmonary TB, but it causes significant morbidity, like especially infertility, dyspareunia, menstrual dysfunction, chronic pelvic pain, inflammatory disease, and non-specific symptoms, and chronic and clinical manifestations, because of which it can be easily overlooked. Next slide, please. So it is seen when Dr. S.N. Tripathi from Odisha did study, they found that out of 100 pulmonary TB cases, 30 of them had genital TB associated, and in extrapulmonary TB, 10% of them may have extra genital TB. And it is typically a disease of young women in India and Asia, like between 20 to 40 years of age, as compared to developed countries where the mean age is 40 years. So this is more significant because this is the time when ladies have to conceive. So that means it causes infertility. Traditionally, 10% of all cases of infertility are because of tuberculosis, female genital TB, but at AIMS, Tertiary Referral Center, and must be same in BHU also, and the prevalence of FGTB in women with infertility was found to be 16%, much more. This is because many patients tend to be referred to AIMS, this is a Tertiary Referral Center from Odisha and from like Uttar Pradesh, Bihar, etc. And incidence of infertility in FGTB was found to be 42%, and almost 8% cases of AUB cases are also due to FGTB. Thank you very much. Next, please. Okay. So now, usually, female genital TB tends to be secondary TB, which will be discussed in the next slide, but up to 1 to 2% can be primary genital TB. That means from the male partner, if male partner has got, AFB positive semen, and also by the sexual contact, there can be involvement of the cervix, vulva, and vagina. So lower genital tract may be involved in primary genital TB. It is very rare. Okay, from the infected secretion from the male partner. Next slide, please. But next slide. Okay, so typically female genital TB tends to be secondary genital TB, almost 98% cases of genital TB, and out of that, pulmonary TB is the most common site from which the tuberculosis spreads from like lungs to the genital areas. But it can also spread from other extrapulmonary side like GI tract because of proximity, kidney, skeletal system, meningeal, miliary TB. So all the more importance is that when we see a case of genital TB, as Dr. Anuradha said in her lecture, we should look for the other areas. This is important. I remember one girl, niece of one of my colleagues, she was having tuborian mass, no sexual contact, unmarried girl. And I was thinking what to do. I was suspecting, female genital TB, but how to take FNAC, how to take endometrial sample, we can't do in unmarried girl. And when we examined the girl carefully, there was a discharging sign on her left knee, from which we took the secretion and sent for AFP. It was group positive. Another girl, she had cervical lymph nodes, in the neck and along with TO mass. So when we took FNAC from the lymph node, it grew MTB. So that means we should find out other accessible sites rather than genital TB, which can be the cause. Next slide, please. Okay. So now traditionally the spread is mainly hematogenous spread from lungs, most common site, and the fallopian tubes are the most favorable leaders because they have got rich vascular supply and the tendency for bilateral involvement, which is sad actually, and subsequent dissemination to other genital organs and peritoneum. Lymphatic spread is less common but can happen from the primary abdominal cavity or consumption of unpasteurized milk, and direct spread from neighboring structure like tuberculous, abdominal viscera, bladder, rectum, appendix, intestine along peritoneal surface. This is important because this ileocecal region is quite commonly involved, and from there the infection can spread to the right fallopian tube and uterus. Next slide, please. Okay, and the sites involved in female genital TB are fallopian tubes are involved in almost 95 to 100% cases, and endometrium, like uterus, in about 70% cases. So this is important because tubes are in 100% and endometrium in 70%. So those 30% patients where fallopian tubes are involved but not uterus, they are suitable for IVF heating in vitro fertilization. So that's why it's very important to know. And ovaries can be in 20 to 30%, cervix in 5 to 10%, 15, and myometrium 2 to 5%. Vulva and vagina are very rare, 1 to 2%, and they can be isolated or single involvement of vulva and vagina can be primary genital TB also. Next slide, please. Okay, so we know that is the we have done almost the side for causes is a significant cause of morbidity, infertility, and dysphagia. Next slide, please. Yeah, this is a repetition. Okay, so it almost occurs secondary to pulmonary TB. That also we have done, and almost 90% cases, and we have done that side. Next, please. So now, what are the symptoms genital? This is very important because in pulmonary TB, patients are almost always symptomatic. But in case of male genital TB, up to 12%, 10 to 12% patient may be asymptomatic. So that's important that even in normal patient without sign symptoms, genital TB can occur. But some patient can have fever with night sweat, but it is very mild to moderate fever, 99 to 100 degrees, not high grade. And some patient may have little bit of loss of appetite, weight loss, poor general condition, but they are not, not there in all the cases. And many times, most of these girls, married women, are typically normal looking. Then menstrual dysfunction is important because initially what happens when there are tuberculosis involve the endometrium, it causes ulcerative lesions. So that will cause menorrhagia. And similarly, in postmenopausal patients, it is an important cause of postmenopausal bleeding in India, apart from endometrial cancer, cervical cancer. So endometrial tuberculosis can also cause PMB. And then so initially it will cause menorrhagia, but later on Mycobacterium will eat away the endometrium, and then patient will have oligomenorrhea, hypomenorrhea, and even secondary or primary amenorrhea can also happen. But amenorrhea and other menstrual dysfunctions sometimes can be because of without involvement of genital areas also, and that is because of the antigonadotropic effect of Mycobacterium tuberculosis toxins. So even in very severe pulmonary TB or very severe miliary TB, sometimes patient can have amenorrhea without involvement of genital organ. So that is important. And then most patients coming to we gynae people are primary and secondary infertility. Some patient can have mass in abdomen, but this is not very, mass is vague. And similarly, they can have abdominal pain, chronic pelvic pain. Really acute abdomen can occur because of secondary supuratory infection. And abnormal vaginal discharge, I want to highlight that almost 40% of my patients of genital TB that had excessive vaginal discharge, and sometimes they may not have complained of it, but when we do examination on PS also, sometimes we can find. So any unhealthy discharge not responding to routine antifungal treatments or this thing you should investigate them for genital TB. Next slide, please. So same way, as 10 to 12% patient may not have any symptoms, same way 10% patient may not have any signs also. That means it's a healthy looking girl but can have genital TB. But there can be systematic examination shows fever, moderate grade, lymphadenopathy, lymph node TB, the associated TB they have got, and then capitation on chest examination. So then we can have abdominal examination, will show mass abdomen, vague or definite. Patient can have ascites, doyfil of abdomen. This is important. But if you get we have seen these girls, so there can be they may have ovarian mass, ovarian tumor. That will be very well defined mass. Similarly, germ cell tumor will be very well defined. But tuberculosis tumor tends to be a bit doughy in feel and vague. And mass. Similarly, on vaginal examination, we can have uterine enlargement because of pyometra or secondary involvement by the acute pyogenic organism. Sometimes there can be adnexal masses and induration in adnexa. So unlike endometriosis, this tends to be a little bit vague. And then tuborian mass again, vague mass is there, and fullness and tenderness in the pouch of Douglas again. If you compare it with the endometriosis, in endometriosis also we have tenderness there, but in endometriosis you have uterosacral ligaments are nodular and tender, which you don't see in tuberculosis. In tuberculosis we have fullness and little bit of tenderness, but not like nodularity of the uterosacral ligaments. Rare signs can be hypertrophic or ulcerative lesion in the cervix, vagina, or vulva, and then labial mass, bathroom swelling. I have seen patients, and I have seen one girl, unmarried girl, no sexual contact, and she had rectovaginal fistula, and it was little bit granular looking. So when I took a biopsy from there, and it grew mycobacterium tuberculosis. Similarly, I have seen a case of sarcoidomal fistula, and I gave her 6 months course of fertility, and then I was planning to do repair of the RVF after 6 months. But have a guess, ma'am, after 6 months when we came, the fistula had healed itself. So I mean, never jump to do surgery in VVF or RVF because of tuberculosis. You have to treat them first with the antituberculous therapy, and after that, if the fistula is persistent, then only we should think of operating. Many times it may just heal of its own. Next slide, please. Okay. Yeah. Okay. So what is important? How to diagnose? As Dr. Anuradha was saying and Dr. Lekha madam, so that is, we should have very high index of suspicion. A family history of tuberculosis or history of antituberculous therapy in a close family member or past history of TB is very important. Now, this I want to, from my personal experience, I want to highlight, man, many of these girls, when they were adolescent or before marriage, they had tuberculosis, pulmonary TB or extrapulmonary TB. But this fact has not been disclosed to the husband's family. Otherwise, it can create a problem, in marriage. So that's why many times my patients, I tell them that, you tell me, I won't disclose it to your husband or your mother-in-law. So that is important. Then only they come out. And another thing, madam, I have seen that some patients, when in India, what happens if the grandmother, grandfather, father, mother, they are having pulmonary TB, so they are looked after by someone in the family, and usually the adolescent girls looks after them, not a boy. Boy works in the fields, etc. And this, because of that, they are doing a good pious work, but they get infection from the father, grandfather, or mother. I have seen at least 7 or 8 such girls, man, whom I knew. One or two girls were they were like sister-in-law of my own worker in my project. That's how I came to know. So that history is very, very important. And then general physical examination for any lymphadenopathy, at any other site, as I told you before, bone joints, as one of my girls had, discharging sinus, and chest examination. Sometimes we do we may get old stigmata of pulmonary TB. And then abdominal examination for abdominal TB, and examination of external genitalia, vulval and vaginal TB, as I disclosed before. Specular examination for cervical TB, and mind you, cervical TB can manifest and can masquerade like cervical carcinoma. I've seen at least 8 patients in my lifetime, and where patient presented had made the diagnosis of cervical cancer and took a biopsy. But the patients were young, like between 25 to 35 years. So that was a bit against cervical cancer. But I took the biopsy, and ultimately report came to be, epithelioid granuloma in the cervix, and that was very good for the patient, So that, and then I gave them ATT, and they became better. And in fact, 2 of them conceived also. So then bimanual for endometrial fallopian tube TB aids in diagnosis of genital TB. Now the test will depend upon the site of TB and its clinical presentation. Next, please. So that's why detailed history taking is very important. And so who should be investigated? That we were part of Index TB guidelines, Government of India, Ministry of Health and AIMS. So then up to any premenopausal woman presenting with infertility, menstrual problems, unexplained abdominal pain or discharge or pelvic mass. And rarely patients having systematic symptoms of fever, weight loss, night sweats. Ectopic pregnancy, cervical, vulvar lesions are rare presentations. And postmenopausal women presenting with vaginal bleeding. So these are the patients who should be investigated. Or whenever you are suspecting any patient having TB anywhere else and suspected to be genital TB associated, so we should do it. And sometimes, like you just PCR is positive alone, then also we should investigate them further for definite TB. Next slide, please. Okay. So now the endometrial aspirator biopsy, the single most important investigation in all sexually active women. So endometrial, just menstrual blood sometimes we do for unmarried girls, but that doesn't pick up good number of cases. So endometrial aspirate to do, and we divide the part into 2 parts and avoid blood in that part. So the whitish tissue is to be taken, and we send it in saline for 4 things. Saline sample, we do AFP microscopy on Jaden stain. We do AFB culture, like it can be MGIT culture, it can be bacteria culture, depending on the lab in your. But I'll advise to all my esteemed colleagues listening to this lecture that you in your own hospital, there are many microbiologists. So someone may be interested in mycology, someone may be in virology. So the person who is interested in tuberculosis should be taken into confidence. And when that person does it again and again, then pickup rate gets better. Like in names, we had Dr. Rusi Singh, so our pickup rate was better. Similarly, like we sent one sample in formalin for histopath. There also many times, because you don't get typical epithelial granuloma into genital TB because of every menstrual bleeding occurs every menses. So that by the time epithelial granuloma was to be found, the endometrium is set. So there is not enough time. So, but an intelligent pathologist who has special interest in tuberculosis may pick up even local lymphocytosis. So there are signs on histopath which can pick up. So our pickup rate got better when we involved Dr. Venkatayya from AIMS in our studies. So I will advise that you involve one microbiologist with special interest in that, and similarly pathologist with special interest. Then the pickup rate tends to be slightly better. And other tests like Gene Expert, also we send one sample for Gene Expert. But others like PCR, Government of India is not saying that we should do PCR, LAMP, LP, just to complete the list. But mainly we do AFB microscopy, AFB culture, Gene Expert. If any of them, the three is positive, if we take it as a positive TB and no need to do any more tests, we can start treatment. Similarly, histopath epithelial granuloma, no need of any other tests, straightway TB to be treated. Only PCR, then we don't diagnose on that basis, but we make it a suspicious case and then we do further test on that. Next slide, please. Okay, so this we have already done that, PCR, Gene Expert. And now what's the role of radiological findings are not very significant for genital TB, but I mean, we have various modalities like hysterosalpinograph. So generally we teach that if the patient suspected genital TB patient, we should avoid HSG, because when you put the dye inside, they can be flare up of the genital TB, or some patients have, but many times because many patients are asymptomatic and no signs and symptoms, so HSG is done as a part of normal protocol to find the tubal patency. So that's why we get many patients coming to us with the HSG report from outside, and when we didn't suspect TB at that time. Otherwise, in a suspected case, we should avoid it. As far as ultrasound, CT, MRI, PET are concerned, don't do all tests in every single patient. Their role is mainly, one ultrasound scan by a person, again, who's special interest in ultrasound. They can pick up even subtle signs like Dr. Sokran and Delhi can pick up very subtle sign we'll be discussing. But otherwise, most of these tests should be done only for tubo-orient masses when we are suspecting TB. And then I'll be discussing endoscopy, laparoscopy, histoscopy soon. So that's also the part. So this is, and I mean, if you do single, Dr. Nwada was also mentioning, if you do single test, then we can pick up, we can miss many cases. So that's why we tend to use the term composite reference standard. That means combination of various tests, then the pickup rate gets better. Like if you depend only on microscopy, endometrial sampling for AFB microscopy, histopath or culture, we pick up and only 10 to 20% cases, 80% cases are missed. But if you depend only on PCR, then you pick up a lot more cases, but false positive also. Same way, radiological finding, I mean, we in our experience only less than 20% patient of genital TB tend to have tubo-orient mass. So radiology will help in that only. So most of our patients were actually diagnosed on laparoscopy, histoscopy done in suspected patients, where we can get findings which I will be discussing. So this all is called composite reference standard, where we combine the various tests and then our pickup rate tends to be as high as 80 to 90% by combination of the tests. Next slide, please. Okay, so yeah, Gene Expert, I mean, is latest test. Next slide, please. Okay. So again, Gene Expert. Again. Next slide, please. Next.
Please mute others.
So this is the ultrasound finding. On ultrasound scan, we can get T-shaped cavity, distorted cavity, fluid levels there, and thinned out endometrium. These are the various findings. Again, I told before that if you involve the person who has special interest, then pickup rate tends to be better. Next slide, please. And we can get tubo-orient mass. Can you see the vague mass on one side? So in case of like if you got a orient mass, it is very specific. In this case, it is less specific. Next slide, please. Okay, next slide. If you can quickly shift the slides, please now. Yeah. So this is CT scan again. We can see like tubo-orient mass and all. Again, MRI. Yeah. Next slide, please. You can keep shuttling. So this is CT scan will show the tubo-orient mass. It will show the lymphadenopathy. Next slide, please. But they're not specific of TB. They can be seen other kind. MRI, again, we can see a tubo-ovarian mass. We can see cages, central cageation also in these masses. Next slide, please. Okay. Yeah. Again, we can have PET CT scan. As Dr. Anuradha was also mentioning, number one, PET CT can show that there is increased glucose uptake in the tubo-ovarian mass. In case of ovarian cancer, the glucose uptake is much higher as compared to tuberculosis, which is moderate. And but what another important use of PET CT, which I use it as an endpoint. So like, madam, patient had tubo-ovarian mass, I gave her ATT, and after 6 months, I repeat the PET CT again. So in my 30 patients of tubo-ovarian mass, in 10 patients, 20% the mass disappeared, but in 10% the mass was persistent even after treating. So then I did PET CT again on them. So out of 10 patients, 5 had still glucose uptake increase. So that means they were still having persistent disease. So I continued ATT to them for another 3 to 6 months. But others, it was just a fibrotic lesion and there was no increased glucose uptake. So my another colleague in orthopedics, they use it every 3 monthly. So some of his patients required 12 months, 16 months, 18 months therapy for skeletal TB. So it can be used as an endpoint for like stopping the antituberculous therapy. So this is our study only in the literature. Next slide, please. Okay. Then, so laparoscopy and hysterosalpingography are complementary to each other. Next slide, please. So okay. So these are on HSC findings. So we can get various types of findings, which I'll be showing in the next picture. Next slide, please. So on HSC, yeah. So you can see there is a shrunken uterine cavity, and the both fallopian tube look like calcified. So this is very specific of tuberculosis, rigid pipe-like fallopian tube. Next slide, please. So quickly we can show the slides. Yeah. Again, in this case, you can see T-shaped cavity and the dye going into the blood vessels and lymphatics, and the tubes are very rigid pipe-like tubes. Next slide, please. Again, advanced TB. But laparoscopy is the most important reliable tool to diagnose FGTB, both tubal, ovarian, and peritoneal disease, because by direct visualization. And this laparoscopy should be by senior persons because of complication rate higher. 360-degree all around, because the TB can be on the mesentery, on the peritoneum, on the bowel, and we can have some signs in the liver, gallbladder also. Plus, sometimes we can find associated other, any pathologies I'll be showing. And of course, genital area we have to see, and ileocecal region also we have to examine. So 360-degree, so that and spend time 15 to 20 minutes to see all around in the abdomen. Next slide, please. So this was the study we found that there were tubercles on peritoneum, ovary, cages, nodule, tuberous mass. Here on laparoscopy, we have some definite findings, probable finding, possible finding. Definite findings include tubercles, cages, nodule, and PD tubes. Others are like hydrosalpinx, pyosalpinx. They are probable signs, tuberous mass, abdominal, pelvic, and perihepatic adhesion. They are probable signs because they can be seen in chlamydia, mycoplasma, gonorrhea, etc. also. And cystitis again, usually it is a probable sign. But when we have like 3 or 4 probable signs, then that may make it like a definite thing. So I'm trying to develop an algorithm like, marking systems like Jones criteria. So hopefully within a year or so, we'll come out with some such thing like that. But till then, composite reference standard we use. Next slide, please. So I'll be showing you the actual pictures of laparoscopy. This is the study we published in IGMR. Next slide, please. Indian Journal of Medical Research. Next slide, please. I'll be showing the picture. Yeah. So we can see when this patient had was infertility, family history of TB, and this PCR was positive, and this patient had hydrosalpinx on one the tube, inflamed tube. So with this, though these inflamed tubes can be there in chlamydia, mycoplasma, gonorrhea, also not specific, to say probable TB, but because of the infertility patient and because of past history of TB and plus PCR positive, so we took it like a tuberculosis, probable TB, and gave her treatment. Next slide, please. Okay, again, this is very specific. There are cages, nodule, and frozen pelvis. In my experience, about 30% patient of frozen pelvis are because of cancer, 30% are because of endometriosis, and 33% are because of genital TB in India. So this is important cause of frozen pelvis also. You can see cages, nodules, and that's the importance of looking all around. Next slide, please. Also, hydrosalpinx is there. So various types of adhesions are fairly common. So we need to look all around. And we found almost 48% patient had perihepatic adhesion. Next slide, I will be showing. And their vascular adhesion doesn't increase doesn't cause much benefits, and it causes bleeding and flare up. So generally, when we are doing some first laparoscopy and hysteroscopy on these patients, we don't do any surgical treatment at that time. We just diagnose the condition, give them ATT for 6 months, and after that, when we do second relook laparoscopy, hysteroscopy, at that time sometimes we do adhesive, etc., but not in the first sitting, because that can flare up the infection, and we have to give them ATT anyway, and there are more chances of injuring the bowel, etc. Next slide, please. Okay, so this is perihepatic adhesion called Fitch-Huggerty syndrome. This has been traditionally Fitch and Hugg reported it in case of gonorrhea. Other authors, mentioned it in chlamydia, mycoplasma, and we observed it in case of genital TB also, almost 48% cases. So, but why do we miss it? Because we don't look into perihepatic area. So, if you look, you will also find. Next slide, please. Again, unfortunately, this is a very sad case, BD tubes and very, calcified tubes. So those, all of you are infertility doctors, so you will find this case will be very bad for fertility, and probably she will require only possibility it will be by doing IVF PT for this lady if her endometrium is okay. Next slide, please. So this is very specific BD tube. And now again, the importance of looking all around. So you can see in this case, the genital organ didn't have much finding, but there are cases nodules on the peritoneum. So importance of looking all around in the abdominal cavity. So she had abdominopelvic TB. Next slide, please. Again, in this case, there is a casus nodule sitting in the pouch of Douglas, right tube with hydrosalpinx and block tube. So again, specific of tuberculosis casus nodule. Next slide, please. Yeah. Again, this patient, as Dr. Anwada was mentioning, she had associated concomitant tuberculosis with endometriosis. So all of you can see endometriotic lesion there, but she has got hydrosalpinx also. And in my experience, in case of endometriosis, you have endometriotic lesions, but usually tubes are patent, fimbria are free. But in case of tuberculosis, usually they have hydrosalpinx and block tube. So that can give you some clue. Usually, if you diagnose endometriosis, we exclude genital TB and vice versa. But we published a study in 18 cases where both were there. So both can coexist because they are so common. Next slide, please. So this patient, you can see the tubercle on uterus. So you can see as if white carpet has been laid on the uterus and fallopian tubes. So these are also tubercles are also fairly specific of tuberculosis. Next slide, please. Okay. Next slide, please. Okay. So this is the hanging gallbladder sign. If you see the first slide, in which gallbladder is little bit of hanging, and there is a basically liver you can see, and perihepatic adhesions are there. In second slide, the adhesions are much more. So the liver gets lifted up as well as gets attached to the diaphragm, and you can see gallbladder lifting up. And in third slide, you can see there is a casus nodule there, and gallbladder is fully lifted up. So hanging gallbladder sign, which we have discovered in case of genital tuberculosis. Next slide, please. And again, same hanging gallbladder sign. Next slide, please. Next slide. Yeah. Okay. So this is another sign we observed. Man, Dr. S.N. Tripathi also say that when we do the laparoscopy and dye test on patients, so in a normal patient without TB, dye just flows through the fallopian tube. You can say free flow of the dye. But in case of tuberculosis, either the tubes are blocked, so there is no flow of the dye, or dye trickles. That means first the dye will fill the fallopian tube, and fallopian tube will look like a blue python, like swollen. But later on, if you keep on focusing there at the pupil, and after 2 to 3 minutes, 4 minutes, the dye may come out also. So delayed spill is there. So that is called delayed spill or block tubes. So it's a blue python sign in genital TB we saw. Next slide, please. Yeah. Now this patient, if you see carefully, man, there is a sign called kissing ovary sign in case of endometriosis. So from that, I found this patient had both fallopian tube got fused to each other. So kissing tube sign, and you can see the casus nodule in the pouch of Douglas, one on the right side. So it's a very specific of tuberculosis. This patient had definitely TB, but like both tubes got fused to each other. So unfortunately, prognosis for fertility will be very poor. So too much love is also bad. So this patient, less likely to go pregnant. But we gave her ATT, and then next time we tried to separate it also. Next slide, please. Okay. And now another thing I observed, because ileocecal tuberculosis is fairly common, and then the ascending colon, then on transverse colon disease much less, and by the time you go to descending colon, the disease almost tends to disappear. But then at sigmoid colon also there can be disease. So on the ascending colon, I have found that lower 1/3 and upper 2/3 junction, there tends to be adhesion of 5-6 centimeter long and 1 to 2 centimeter broad. So ascending colonic adhesion sign I have found in many patients, 30% or so. So if you carefully look in that area, we can find this sign. Next slide, please. And yeah. Okay. So then again, again, next slide, please. We have already done this. So peritubal adhesion and others are there. Again, same ascending colonic adhesion. Next slide, please. So adhesions are very common, almost 40. Yeah. So this is this patient is a case of liver cirrhosis, not genital TB. But I want to highlight the importance, of looking all around the abdomen. So this patient has cirrhosis, and then we sent the patient to the hepatologist. Not that I did any biopsy or anything, so that patient can be properly treated. Otherwise, this was missed. So that's the important. Another patient we saw, liver hemangioma. We didn't do anything to that, but we referred the patient to the suitable doctor. So that is the importance, looking all around. Next slide, please. Okay, then dried tree branch sign. I have shown this slide before also on the HSG. You can see sunken uterine cavity, and both tubes are calcified. So unfortunately, bad prognosis. So it's a dried tree branch sign. Next slide, please. Same thing when we did laparoscopy on this patient. Then we found the fallopian tubes were blocked and calcified. Okay, and then same thing. Another sign is parachute sign. So next slide, please. I'll be showing the next slide. So parachute sign will be, if you can you shoot the next, yeah, sorry. Yeah, okay. So if you see carefully, when this is ascending colon. So when I put a laparoscope through the navel button, and then I wanted to put the right port, and suddenly I saw this ascending colon adherent to the anti-abdominal wall. So this had got practical significance. If I put the second port, I would have gone straight away through the ascending colon. So never put the port without properly seeing the colon, and always put on the left side, because descending, by the time the disease is very much active in ascending colon and tubular mass, but when you come to the descending colon, the disease tends to become less. So it's better to put the port on the left side. Like there is a Jan point also on the left side, so that's the reason. So never avoid putting the probe on the right side. Next slide, please. Because there is a risk of injury. Same thing, this patient, you can say. So on how can I say it is genital TB? You can say there was tubercles and cages nodules in the mesentery of the ascending colon. So that's why we can call it abdominopelvic TB. Next slide, please. Okay, and so I have also observed that a sigmoid colonic adhesive band. Next slide, please. I'll show that. So I told you that descending colon doesn't have the disease, but then this sigmoid colon, there is a band again in some of these patients. Next slide, please. I'll show the next. Yeah. Next slide. Can you, yeah, again. So you can see sigmoid colonic band is there in case of genital TB. Some of these cases, not all. Next slide, please. So other type of adhesions are also important in this, as shown in this slide. Next slide, please. Just quickly, if you keep shifting the slide. So these are other type of adhesions which can occur all around. Next slide, please. Okay, and then I also found that just like in peritonitis, when there is compartment sign, so same way in tuberculosis also, nature tries to basically localize the disease to right lower segment, left lower segment, upper segment, like that. So this is called abdominal compartment sign. Nature tries to localize the disease to one part. So this also I observed in genital TB and abdominal pelvic TB. Next slide, please. Okay, and this is a case, actual case, man. The patient belonged to very rich family, and this case was referred to by our HOD medicine to me, and he told me that he had treated this girl in unmarried state for pulmonary TB, but this fact was hidden from the husband. I was told not to disclose it to the family. So I saw the patient as a new case, and when I did laparoscopy on her, you can see I had never seen anything like that. There was a 5 centimeter into 4 centimeter white cotton ball, or you can say snowball sign, almost 2/3 the size of the uterus. And I couldn't even see the fallopian tubes, and there were adhesions, you can say other cases, nodules also. So I gave her ATT for 6 months, and I never thought, and I said, you straight away go for IVF after that. And to be honest, I never thought that she will ever be pregnant even after ATT or IVF. But last year I got a phone call from her. She said, sir, doctor, they are doing, Dr. Sonia Malik, I can name also, did the IVF for her, and it was successful. And she rang me that they want to do cesarean on me. What do you think? I said, when did you fall pregnant? I was so happy for her. So cesarean was done. A baby girl, now 2-year-old, is there. So that's a success story. I mean, so it's a cotton ball sign. You can say last sign, and this patient has conceived after IVF ET. Next slide, please. Now she's time for the second baby. Yeah. Okay, so same thing. So now we can say algorithm type of thing, it is found in these patients. So, okay. Okay. So TB algorithm, and then histoscopic findings, and maybe my other colleague later on will also find. So on histoscopy, we can see, normally the cavity is fairly pink, and you can see both ostia, and there are no periosteal adhesion. But in case of genital TB, man, the cavity tends to be a little bit whitish in color. That means pale cavity or whitish cavity, and there are then adhesions in this thing. So, and then, periosteal adhesions are there, and sometimes you can see tubercles also, you can see cages nodules also. So there is one from Rajasthan doctor. I think one doctor has done a lot of work, Atul, I think, and all couple on histoscopy. So these are the various findings you can see on histoscopy. So that's why laparoscopy histoscopy combination will tend to pick up more cases. Next slide, please. Okay. And then, this patient, sometimes the genital TB, abdominopelvic TB can masquerade like ovarian cancer. So I did laparotomy for this patient on the diagnosis of ovarian cancer. But when I opened the abdomen, I could see the cages material, everything was fused to each other. And I just took biopsy, cages material was there. And, I just took a mental biopsy and didn't proceed further. So please, if you open a patient for ovarian cancer or any other condition, never try to do THBS on such patient, because everything is adherent. And if you try to forcefully do, it won't serve much purpose. We have to give her ATT anyway, but there is a risk of injuring the bowel, small and large bowel, and even the bowel surgeon will have difficulty in taking this because the planes are not there. So, so we have seen, but on the other hand side, I have also seen patients of ovarian cancer being diagnosed as tuberculosis and being given ATT. That is a bigger sin. So if any doubt, it's better to do laparoscopy or laparotomy. And if you find tuberculosis, just, give her ATT and come out. Don't try to do complete surgery. Next slide, please. Okay. So, but we observed many increased complications on laparoscopy and as well as histoscopy for these TB patient as compared to non-TB patient. 31% complication rate as compared to 4% in non-TB patient. Like they were not major, like, inability to see pelvis, excessive bleeding, peritonitis. And in 1 or 2 patients, we had bowel injury also. 1 patient, we had bladder injury. Out of, we had done nearly 800 or plus cases. And I'm thankful to Government of India, Ministry of Health. They gave us 3 projects, man, over 15 years of something 70 to 80 lakhs. So almost 2 crore rupees were given to AIIMS by Government of India to do research on TB, because of which we could do a lot of good research. And I'm getting letters and appreciation letters from USA, Canada. The doctors are discussing with me. So I want to highlight to all my esteemed, please do work on this area. It's an important area. May not be very glamorous, but patients are having it. Next slide, please. Okay, and should be done by senior person. Okay, so sometimes now, what happens then, after 6 months of therapy of ATT, then because it was our project, when I always repeat laparoscopy and histoscopy on them, unless like that patient, I said, go straight away 5 years. So what happens now, if you do after 6 months, then we can plan further. There can be 3 scenarios, like number 1, her tubes are also open and endometrial cavity is fine. Then she can try normal conception with ovulation induction. Second scenario, that of course you will be discussing, I think, in fertility lecture. I won't go into detail. But second scenario is tubes are blocked, but endometrium is fine, or grade 1 to 2 adhesion which can be cut. Then you can do IVF PT for them. Third scenario is tubes are blocked, endometrium has got grade 4, 5 adhesion which cannot be cut, but ovaries are fine. Then you can go for surrogacy. Fourth scenario is, madam, I have seen patient where even ovary has been eaten by the tuberculosis. Then this patient goes for adoption. So at least we can give them, after, clear cut, they don't have to sell their house or piece of land, and, and can adopt a baby if need be, or like this. Next slide, please. But rarely we can do drainage of the abscess and all. So treatment plan is by a National Tuberculosis Elimination Program. You can refer these patients after making the diagnosis to your TB dot center, and the drugs can be given free of cost to them, and they are given 1,000 rupees per month for portion also. And then they are automatically reported to the government, because now we have to report these patients to the government through their system. Next slide, please. And so all patients are given category 1 treatment under DOTS. I'll be just showing. Next slide, please. Okay, so this is, you don't have to go into detail, but these days, they give it, the treatment is given as weight band wise. But roughly simple form, I say, the patient is given RHZE, 4 drugs, rifampicin, isoniazid, ethambutol, pyrazinamide, daily for first 2 months, and then RHE, stop Z. So isoniazid, rifampicin, and ethambutol daily for next 4 months. So 4 drugs for 2 months and then 3 drugs for next 4 months are given. So you can use this pay band, and if you refer the patient to dot center, she gets free treatment from there, and then they calculate the band also. Otherwise, if you patient wants to take from the market, their company products are also available, like AKT4 from Lupin is a very good brand. AKT4 daily for first 2 months and AKT3 daily for next 4 months, or CX5. CX5 contains the pyridoxine along with. So that can be given, and then CX4 contains pyridoxine also. So same thing, in other words, RHZD daily for 2 months, RHE daily for next 4 months is given. Next slide, please. Yeah. Next slide. So rarely patient can have drug-resistant genital TB also. That is the beyond the scope of this lecture. In that case, you refer the patient to experts. In that case, the patient will have to be given bedaquiline, moxifloxacin, and other drugs, which, but take the opinion of that, because their drugs have to be given 12 to 16 months. And so I won't go into detail of that. We shouldn't treat them for drug-resistant. It should be done by the experts, because these drugs are toxic and they are very expensive and under supervision. Next slide, please. But there can be some cases of that. So this, we have already done that slide. I mean, the same thing algorithm. Next slide, please. So I'll just, next slide. Okay. Yeah. So I already said that. So we can give them AKT4, AKT daily, or CX5 daily for first 2 months, then AKT3 or CX4 daily for next 4 months. Next slide, if they want to buy. Otherwise, they can get from the dots also. Next slide, please. Most patients will tolerate ATT safely, and we can do the liver function test, but some amount of derangement of liver function test is common with them, but the drugs can cause hepatitis. If the patient has loss of appetite, patient is feeling very unwell, then you do LFT. In that case also, we can stop the drug and gradually we start one drug at a time, like that. So, but in that case, I won't go into detail of that. It's better to take opinion of the expert, and all these patients will ultimately require, be treated by all 4 drugs. But then we start one drug at one time, and this time is not counted. Suppose it takes us 1 month to start her all 4 drugs again. In that case, this 1 month is not counted. We have to give them complete 4 and 3 drugs regimen. So she may get 7 months therapy. Next slide, please. Okay. Okay. And I told you surgical treatment normally not to be done. And but if there are pyogenic if there are abscess, then we can drain that abscess, or laparoscopy, histoscopy before and after therapy is to be done, as I told before, because then we can plan further treatment for them. Next slide, please. I almost finished then. Yeah. And this part I will not discuss, because assisted reproduction, I think Dr. Madam Asha Baxi is also there, and my other colleague will be discussing that. But definitely, like after treating them, assisted reproduction is a good modality for them if the tubes are blocked, but endometrium is either normal or grade 1 to 2 adhesion, which can easily be cut. But if beyond 4 or 5 grade adhesion, which you can't cut, or endometrium is not there, then unfortunately it will also not work. Next slide, please. So because infertility is a separate lecture, so the same thing basically, I just last slide. So in this case, same, we have done it, but I'll just repeat it, that whenever you get a suspected case of male genital TB, we do endometrial sampling on them, and sample is sent for AFB microscopy, AFB culture, and gene expert, and histopath. Any of those tests are positive, it's definite TB, start it to the patient. But if only PCR is positive, or patient has got other symptoms, or then we can do ultrasound, CT, MRI, PET, one of those tests if there is a patient has got TO-mass. So positive PCR with TO-mass, then you can say probable TB, you can start treatment. Or positive, then otherwise just only PCR positive, or you are suspecting TB, but endometrial test is negative, then we do laparoscopy, histoscopy on them. On laparoscopy and histoscopy, you can have definite finding like nodules, cages nodules, BD tubes, or tubercle. Then this is a definite TB, start ATT. Patient can have hydrosalpinx, pyosalpinx, stroke-alert fluid, perihepatic adhesion, peritubal adhesions, and other this thing. Then probable TB, again start treatment. If there is more than one finding, then further more. But if the patient has got only positive PCR, but everything else is negative totally, then Government of India, Ministry of Health doesn't allow us to that. But if you feel that your patient has got genital TB, so you can say that positive PCR plus clinical suspicion and some laparoscopy, histoscopic findings are there. And then you are allowed to start AT to that patient. So thank you very much. We can stop here.
Thank you, Dr. Professor J.B. Sharma, sir. It is always a pleasure to listen to your lectures.
Thank you.
And I have had the the extreme happiness and pleasure of listening to sir a number of times. Every time the lectures are mesmerizing. And I've also read the complete article with composite reference standard a number of times and even taught it to my students.
Oh, thank you, man. Thank you, Dr.
So,
Monica. You are yourself a
so
brilliant
much
teacher, man.
recognition I got because of your lectures. Whenever I read excerpts from your lectures and tell them about CRS and the way tuberculosis diagnosis and management has become easy over the years in India because of the CRS, it's very well accepted and appreciated. Thank you, sir. Thank you so much.
Thank you. My pleasure. And thanks for the opportunity.
Sir, you make whole lecture sound so
Hi,
easy.
Dr. Rakhi.
Hello, sir. You make the whole lecture, the difficult topic sound so easy, and it is just like a cakewalk that you do this and do this and do this. And it's so easy to diagnose in this. But definitely all the viewers would be benefited with all the slides and your images, because audiovisual leaves an impact on everybody's mind to understand how to diagnose. Now your images, if they've seen that this is the parachute sign, this is this sign, it is very easily explained with the evidence base. Hats off to you, sir. Always you make all
Thank
the
you.
look
Thank
so.
you, Dr. Rakhi, and best of luck to Dr. Rakhi for her lecture.
Thank you, sir. Thank you, sir.
Best wishes, madam.
Thank you, dear. Thank you, dear.
Sulekha, madam, your blessing needed.
Thank you very much. Only one question I have. What about your opinion about the government's policy that every case has to be registered and it cannot be treated by the practicing gynecologists and all, because they would like to give you the medicine free and it needs to be registered. Either when you tell the patient to come back, they may not come back. And what I find, the dose given initially, the patients are not able to tolerate, and then they leave the drugs and get a haphazard treatment. So what is your opinion that
Yeah,
government?
madam, it is important, man. Like, though most patients will tolerate them, but some patient, I remember one girl, she couldn't tolerate any drugs. She had hepatitis, so we had to stop all drugs to her. But then we started ethambutol is the least hepatotoxic drug. So we started her ethambutol with levofloxacin, which is not normally given. My doctor, our Professor Randeep Guleria started her. And then after 1 week, gradually another drug like, this isoniazid was started. Then after 1 week, the third drug, rifampicin, was started. And then the fourth week, pyrazinamide was started. And then this levofloxacin was stopped. And during this time, she was given Leaf 52 or other, liver tonics, etc. So it took almost a month, but ultimately she was started all 4 drugs. And then, but this 1 month was not counted, and ultimately she could complete all the regimen. But we need to take the help from our TB experts, colleagues, or physicians, whosoever have they, like in BHU, have got a very brilliant department. And as far as madam is rightly said, we have to register these cases. It has become law. And but though till now, no, they haven't punished anyone not to report. But yeah, so for that matter, what I used to do in AIMS, I would like, laparoscopic evidence of male genital TB, category 1 ATT, referred to AIM.center. I would put my sign stamp, this. So I refer the patient to them. Sometimes they will grumble that no, it is not TB, because they want to give only for pulmonary TB. But when I signed it and put my name and all, they had to give it. And then this referred the patient to the dot center related to the patient's area. Like some of the patient came from Uttar Pradesh also. So the patient is referred to the whole India is part of DOTS, so that we can use the help of them. And another thing I'll advise, madam, like in wherever any of you are working, so you involve a DOTS person. The TB doctors are very good. They are government doctors. They are willing to come and deliver a talk to you. So make a rapport with them. They want to be our friends. They are not our enemies. And we have always taken help from them. And in that case, like if you have any issues about, like initially even I had problems, I didn't know how to treat their TB drugs reaction. So we had a friend, in fact I treated his wife, but in TB he was better than me. So I used to call him, and he would treat all my patients. And then I learned from him how to, he said stop all medicine, and then he said start ethambutol, which is the least toxic, then another one, like that.
Sir, can I ask one question?
Yes, sir. Yes, sir.
Dr. Surekha ma'am, basically it is a team approach how we need to work.
No, but
Reporting
the
is
problem is,
important, but we need to be in touch with the patient also. Whenever
Absolutely.
the patient is gone, whatever the patient is facing, let them come back and report it to us also. Because once we have a rapport with the patient, we can enroute and clear off their problems much easily, so that then definitely the patient is also not lost and has the confidence of continuing the treatment also.
Sir, can I ask one doubt?
Yes, sir. Yes.
Sir, suppose if there is an say additions which are suspecting SN and as a tuberculosis, and the tissue diagnosis is negative in laparoscopy or hysteroscopy, at that time, just like when I mean, not an expert like to somebody, a routine laparoscopy surgeon in a non-government settings, then how will they proceed, sir?
Yes, sir. That's what I said. Only, sir, 15 to 10 to 20% patient will have microbiological evidence of TB. So even when we are doing laparoscopy, histoscopy on them, they are negative on microbiology. Even if you send sample, I have seen, sir, I have taken biopsy from cages nodules, still it doesn't grow bacteria. So, or from any lesion. So, like microbiological evidence is very rare. But you can write, sir, laparoscopic evidence of abdominopelvic TB or female genital TB. Like cages nodule is definite TB. BD tubes are definite TB, tubercles are definite TB, others are probable TB. So we can write laparoscopic evidence of male genital tuberculosis or abdominopelvic TB. Even without microbiological evidence, we are allowed to treat.
Okay. So will in those cases will there be the length of treatment differ from those
No,
with
sir,
the
it will be same 6 months only. The treatment is same 6 months. RHD daily for 2 months, RHC daily for 4 months, like that.
Oh, okay. And next thing is that suppose I have seen a lot of times when there is addition, if you are not sure, surgeons will go on doing the adhesiolisis before the medical treatment. So what is your take on that? It is not advisable that message. A lot of the times when enthusiastic lab surgeons go on doing the adhesiolisis without, if you are suspecting tuberculosis, we have to first treat medically. Then only we have to go for the definitive treatment. What is your advice, sir?
That's what I mean. Sometimes initially I also used to cut adhesion because you feel so tempting, no, like that. But then I realized that there were more complications in them. Some had flare up of the TB, and the adhesion tend to come back also, and we don't gain much. Many of the adhesions are away from the fallopian tube, so we can leave them alone at that time. And just like, because there are more complications, they are more vascular and more complications, and you don't gain much. They are not going to increase the pregnancy rate, and this they are silent. So like peripatetic adhesion, I almost never cut them.
Because you touch it in that flare-up zone, when you've not put the medical treatment for these patients, it flares up the whole scenario.
Absolutely.
Biliary tuberculosis or the you sending the tuberculosis bacteria to every nook and corner.
Yeah, patient can become very sick. Absolutely.
And the patient really becomes sick, and then we're doing more harm than the good to these patients. So never seen out.
Doctor, there are a few questions in the chat box. Can you take that?
Yes. Can someone read? I can't see.
One question is, while doing TVS scan pelvis in a woman, with woman, infertility uterus and tubes are normal, but fluid in the pouch of Douglas. What is the best way to diagnose tuberculosis?
Yeah, actually, sir, that fluid in the pouch of Douglas or even small ancestral ascites, they are this is one of the many signs of TB, but not alone is not adequate to start ATT. Because some fluid can be there in other conditions, so chlamydia, mycoplasma, and other conditions also. So if you have to have some other associated conditions, so in that case, you will need to take endometrial sampling. In any case, has to be taken and try to do endometrial sampling for AFB microscopy culture and all. Or like if we are suspecting, then better to do laparoscopy and histoscopy on these patients. So just by seeing some fluid, I mean on ultrasound, we can't start ATT.
One more question, Dr. Aki. Can you take the question? Is from Dr. Mani Mukta. In infertility cases, if the female partner is TB platinum positive, should male partner be investigated?
Yeah, this we did study names are actually all infertility patient, and we did their husband semen for PCR. And
But
sometimes that also grew positive PCR, but then when we did all the other detailed tests, they were all found to be negative.
it
So
normally doesn't comes positive for, if the female is positive, it is always there that the male comes positive. It normally doesn't happen. It is just like that one of the family member is having pulmonary tuberculosis. Others are at risk, but all the other family members will not be there positive for the tuberculosis which is there. Only once the immunity goes down for that person, then only it happens. So it is not always true.
yeah, and
Very
genital TB
true.
almost never spreads to other. In fact,
Yes,
whenever the
yes,
patient, whenever I diagnose genital TB, patient becomes little sad. Then I call her inside, her husband also. I said, no, don't confuse it with pulmonary TB. ये
yes.
basically ये छुआछूत की बीमारी नहीं है. मैं उसको हिंदी में बोलता
It
है.
will never,
So
it will
it won't.
never.
So मैं उसको बोलता हूँ, don't disclose to anyone. You cook food, रोटी बनाओ, सबको खिलाओ. आप husband से मिलो, sex करो. No, it won't spread to him. It won't spread to anyone else. No need to tell. Even के है भी है, ये भी पक्का नहीं है. So then suddenly smile comes on her face. I said, हम treat कर रहे हैं because we are suspecting it, and from our experience, and if you give her you ATT, your chances of falling pregnant will be higher. But this is not a disease which will spread to others. And then, that's we had to tell her clearly.
Counseling
In
people
male partner,
here.
if you are getting a lot of percents, 20, 30, then rather suspect male
Yes,
tuberculosis.
Yeah,
yes.
then we should manage. Yeah,
Then definitely, ma'am.
genitourinary TB is fairly common in men also in India. So then they have to be seen by the urologist, and if need be, we can do their semen for culture, semen for PCR, and we have found some cases of tuberculosis, orchitis, and other conditions.
The basic bottom line is that every person in India is harboring the tuberculosis bacteria, but it becomes sensitive and it turns out to be symptomatic only in those cases when the immunity goes down and suddenly there's a weight loss or there is a health crisis, then it takes over and then becomes evident. Otherwise, it is never positive with tuberculosis.
I
Absolutely.
mentioned in my say that there's a tall receptor and SNP polymorphism that runs in the family also, and they are more prone for this genital FTB and also male infertility.
Yeah, maybe, madam. And don't think that it is in the
Yeah.
poor family. I have seen it in very
Yeah.
rich families also, madam.
Yeah, that's why I'm saying. I read an article that they've done this study done SNP polymorphism and also this tall receptor 2 study.
Yes, madam.
Yes.
They're doing lot
Yes,
of
sir.
work studies.
And so because of mostly, I mean, if you see the recent generation, they are BCG vaccinated. So it's already there dormant. So Dr. Raki, what I want to say, it is not only inside the body, it is outside in the environment.
Everywhere.
Can go in. So yes, that immunity factor, and if it goes down because of any reason, then we can have a reactivation of even those dormant tubercle bacilli, which can be transported anywhere
Very
to
true.
cause whatever the problem they are causing.
Very true. Very true. Superb lecture, sir. And a good
Thank you, sir. Thank you very much.
Wonderful lecture,
Yeah.
sir.
Thank
Sir, is there any significance of TB gold test?
But TB gold,
Just
government,
like-
national NTEP, they don't allow to do this
Yes.
TB gold and quantiferon. They are not, allowed to be done. And but I mean, if you had done them, all of them, they will show screen positive. Screen positive
sir.
means need to do further
Yes,
test,
further
CRS.
test.
So if you had done quantiferon, if you believe in it, don't start ATT. You do leprostro on that basis. They say PCR is also, we do laparoscopy, histoscopy on all PCR positive patients. If we don't do quantiferon ourselves, but some patient has done from outside, because then it becomes very difficult to deconvince the patient, And somewhere you also feel that if it has been done, either you don't do it. If you're doing it and it's positive, then we don't start ATT, but do leprohisto. If on leprohisto you find findings, then you start ATT. So you can use it as a screening method.
Yes.
Yes.
I think this is the main doubt and confusion, sir. And this is
Actually,
what I think.
yes.
What Anu is saying is the main doubt and confusion, and this is what small brief which I'll be talking, and this is what is causing a lot of confusion, that
Yeah,
whether to treat or not to treat.
We wait for
And,
Dr. Ekika's lecture. Absolutely, that is. So still, some controversy will always remain. It's not easy
Yes,
to,
sir.
because possible accelerated disease. So even now, I feel some of patients I might have over treated. I agree. I accept that. But and another important thing is that when we start, many times when I get the patient, ATT has been started and then patient fell pregnant, they stopped ATT. Don't do that.
Yeah.
Either you don't start the ATT, because tuberculosis not only causes infertility, it causes implantation failure, it causes miscarriages also. Many of my patients who conceived, they had preterm labor. Some had miscarriage also, because endometrium blood supply gets less in case of TB. Once you start ATT, then vascular supply becomes better and the chances of ongoing pregnancy are higher. But still, many of them had abortion, many of them had preterm labor also. So this is always possible. Thank you. So we hear Dr. Ekika's lecture. I think we very eagerly awaiting, man. Thank you.
Yeah, let's move on.
Thank you, sir.
Thank you. Thank you. Thank you. Thanks for the opportunity.
Thank you, chairpersons.
Yeah.
Thank you very much.
So coming to our next session, which is genital cox and infertility. And for this, I would like to invite our chairpersons, Dr. Seema Pandey. We all know her. She has done her fellowship in minimal invasive surgery, a fellowship in reproductive medicine, fellowship in regenerative medicine and stem cells diploma in USG. And she has many certifications and achievements to her credit. And she is Secretary UPSR. Welcome, Dr. Seema.
Thank you, Anu.
And yes, librarian Dr. Suparna Banerjee, our next chairperson. She is Secretary of ISAR Bengal 2024-2026, Secretary of Scientific Committee of Yuva ISAR, Assistant Secretary of Scientific Committee of AICOG, Secretary of Self-Fertility and Reproductive Endocrinology Committee of BOX. Welcome, Dr. Suparna.
Thank you. Thank you, Anu.
Yeah, you're most welcome. And our next chairperson, she's Dr. Tanya Bakshi. She is Director RCOG MHC ST Specialist Training Program, Director IVF, Reproductive Medicine and Onco Fertility, Max Super Specialty Hospitals, Delhi and NCR. Welcome, Dr. Tanya. So over to you, chairpersons.
Dr. Seema, can you introduce Dr. Ekika, please?
Yes. Hi, this is a pleasure introducing my neighbor, younger sister.
Seema, you are not audible.
I think so. We can go ahead with the slides.
No. Yeah. So Dr. Ekika is heading Sharda Narayan Hospital and IVF Center. She is Diploma in Reproductive Medicine, Hamilton University, London, and Germany, Kiel. Managing Director and IVF Consultant, as I already told you.
अरे यार ऑपरेशन करना पड़ गया तो अगला बच्चा कैसे करोगे? 2 साल बाद.
Dr. Anu, can we have you on mute, please?
Okay. Cannot mute her.
Sorry, I lost my connectivity. Am I audible now?
Yes, you are.
Yeah. And she has posted presentation, Ashray RCOG Kogi, paper presentation in various national and regional conferences, chapter contribution in multiple books, and articles and research work in journals of ISAR Express, committee newspaper. She is been doing a lot of research work, role of progestin prime awareness stimulation in IVF ICSI, embryo glue, its role in RIF, evaluation of high basal LH on IVF ICSI outcomes in PPOS cycles, role of platelet-rich plasma in thin endometrium, and evaluation of combination therapy, inositol, antioxidant, and vitamins in PCOS, multicentric retrospective observational study. Ekika is President Mao Obstetric Gynae Society, member of Management Committee ISAR, Executive Member UP ISAR State Chapter, North Zone Coordinator Foxy Young Talent Promotion Committee 2022, Assistant Editor, International Journal of Human Reproduction Research and Development Publication. And welcome, Ekika, and we are waiting to listen to you.
Thank you, Seema Di, for giving such an elaborate description of mine. I mean, I'm too young to talk about what is the vast experience of JV sir is there. And I have been a student when he was in MAMC, and there was a lot of work on R&D which is being done by him. And it's excellent that it's good to be a student of such a excellent teacher. And now I'm sharing my slides. So is it visible?
Yes, ma'am, it's visible.
Yeah, okay. So this is female genital tuberculosis. So, and I have to talk about genital coxin infertility. Well, what I want to say, it is a gray zone, a very big area, and a lot of confusions are still there when it comes to treating a patient who is infertile, and again thinking that she might be having genital tuberculosis when we don't have many sure shot signs. So as already been told by sir, the way it is spread, and since everything is being beautifully explained by sir, the epidemiology and the percentages, I just want to say this is how the tuberculosis does spread to the genitalia. It could be reactivation of the latent TB, hematogenous spread, lymphatic spread, direct spread, and yes, to some extent, sexual contact, that is intercourse with a male partner suffering from genital tuberculosis, which is very rare when it is said. But yeah, in our country, we can not say that it is very rare cause of genital tuberculosis. So what are the four factors that we assess when we, the basic four factors which we assess when it comes to fertility potential of a female? That is whether she's ovulating or not, there is good ovulation, what is the status of the uterus and the ovaries, whether tubes are patent or not, and what are the semen parameters. So when all these parameters are normal and patient comes to us and she's infertile, we don't have an answer to it. And yes, in most of the cases, it is being designed as unexplained infertility, which is being diagnosed. So unexplained infertility is the part which is the gray area. And in practice, basically what generally we have seen, and since we are also running a center, many a times these patients who are of unexplained infertility are being either treated that empirically they might be having TB, or as sir said, that TB good interferon is the test which is being done, which is being widely used and widely it is being advertised, which is being done. And if it is positive, the patient is being started on TB, ATT drugs. So the pendulum is whether to start or not to start. What we have to think, what is the real implication and indication? So this is what is we have to keep in mind, and we have to be really careful while starting the medication as a beautiful algorithm in the end, which is being shown by sir, that if it is this, then we have to go like this. If it is this, then we have to go like this. This all of us have to keep in mind. Just doing a TB interferon or a Mantux in a patient who is having infertility, is starting ATT justified? This is an open question to everyone, and I would definitely want my seniors, Dr. Anurag Khanna, JB Sharma sons, and even other to really give their opinion, what is the right thing? Because I don't find a lot of, yes, when it comes to Indian government recommendation, latent TB is not to be treated and not to be even investigated. So what should we look for when we get such kind of cases? History at its spread, if they have TB, they had ATT, history of TB in past, or if even the family is having this history. Low socioeconomic status, poor living condition, menstrual irregularities, and there are some other symptoms which have to be kept in mind when we are treating these patients. Not only this, the physical examination, specifically looking for the evidence of lymphadenopathy, which is after pulmonary tuberculosis, are sometimes which patient really come and show you, see, I had this node, this swelling inside for which the biopsy was done and I was shown to have TB. Then pelvic examination, as this thing is already being detailed by sir, restricted mobility of the uterus, TO mass, abscesses, even the ultrasound showing teomas and cystate collection as being told by sir, the cyst, the hydrosalpinx, and HSD. Tubal block, especially mid or distal, lead pipe appearance. These are the things which you should be looking for. And if we have doubt, then yes, of course, the laparoscopy and hysteroscopy along with the microbiological investigations which are being told are the one which can help us to define whether the patient is having infertility because of genital tuberculosis. So still after saying this, I must tell you, GTB is genital female tuberculosis is a silent contributor of infertility in reproductive age groups. Why is it so? As being said by the sir, there could be unspecific symptoms, like in young girls, specifically initially the phases of menorrhagia, metrorrhagia, hypomenorrhea, oligomenorrhea, amenorrhea, pelvic pain. Specifically, as sir said, initially they might be having menorrhagia, and slowly, if we really dwell deep, we can really ask them and find out that they might give you a history that they had menorrhagia, and slowly now they have scanty menses. So these are some things which we should keep in mind while taking a history of an infertile patient in the reproductive age group. Not only this, there are many unusual presentation, definitely said by sir, and these two are the ones which I took from the papers. That is, a cervical TB patient had polymenorrhagia, post-coital bleeding, specular examination showed a congested, angry-looking cervix. And yes, cervical carcinoma was strongly suspected, and the HP showed that it is a tubercular cervicitis. So the improvement after the ATT was really remarkable in this case. And this is again a case, this patient, according to the author, had a secondary infertility. And the patient presented with vaginal discharge, post-coital bleeding, lower abdominal pain. Endometrial tissue sampling was positive for gene expert. ATT showed marked improvement. So as sir said rightly, vaginal discharge and post-coital bleeding are two very important things which we should be keeping in mind, even if the patient has not come to us because she might be in the younger age, or she might have had one child and now she has presented with this. So having a keen acumen can really help us to find and to stop the fatal effect of tuberculosis when it progresses. And so these are the two cases which we really had. This is a recent case which we took care in at our center. This patient is menopausal. She was 43 years of age, case of primary infertility with amenorrhea more than 1 year. So we did an ultrasound. It was a small uterus and ovary, and hormonal range was also the menopause. So she was started on the priming. We asked her the history and everything, and somehow nothing was elicited that she had ATT or she had taken any treatment for that. We started her with the priming, and estrogen and progesterone given. Though there was a growth, the growth was in the uterus and even the endometrial lining was there, but it was not satisfactory. It was a bit irregular. So after giving her priming for 3 to 4 months, we spoke to the patient. We said we are not finding a good growth in the endometrium. So we would like to do a diagnostic laparoscopy for her. So once the moment we did put the scope, we found the tubercles present on the tubes and the POD at multiple sites. Biopsy was taken and it came out to be positive. And we started her on ATT. So I really don't know. I mean, she has just started her ATT, and it is at the second month of the treatment. So probably this amenorrhea is because of her menopause. We say it as a menopause, or whether it is because of the tuberculosis. This is what, again, it's a question for us. And then only after the treatment we'll come to know. And this is one also a very good case. This girl came to us. She was 26-year-old with primary infertility. And she gave a history of emergency laparoscopy when she was 15-year-old for acute abdomen. At that time, it was thought to be appendicitis, but there was a mass which was removed, and it showed tuberculous epithelioid cells, and she took the treatment that time. So, I mean, she took the treatment that time, and after the treatment, her one side of the tumor, obviously, that was removed by the doctor, as what we got in the note. Even after the treatment, she came to us with an HSG report, which showed that she had a blocked tube on the left side. So this was on the right side, and she took the treatment. And even after the treatment, because she was trying and she was told by some doctor to get an HSG done, and then they showed a blocked tube on the left side. So we obviously convinced her to go for, because, and she wanted, ki, ma'am, please kindly do something. Can't we start any medication? Can't you do a surgery to open my tube? I really don't want to go for IVF or any other assisted reproductive technology so early. We did a laparoscopy in her, and there was a lead pipe appearance of tube, totally fibrotic. Tissue was sent from the tube and the endometrium. though it came negative. So what I want to say by this case, I mean, though this patient was already started on ATT when it was found, but still she had a sequelae. Even after the course of ATT, she had a sequelae and she had a lead pipe appearance. And not only this, now this patient, the problem with us was that she had an AMH which was low and she had only 4 to 5 AFC, endofollicle count. So this is a tough patient at 26-year-old with low AMH and low AFC count. And then we have to take her for assisted reproductive technology. And probably next month, we might be stimulating her. A word about latent effect of latent TB. This is the report of 2019 and 21. See, in this report, it is being showed that IGRA positive, that is TB gold positive, which are the tests, it shows near about 31.36% of population of India is positive with the latent TB. As it is said, latent TB is quite endemic. It's a huge population which is having latent TB. But on the same time, it again said that the tuberculosis which was diagnosed, in that if you see, the past history of TB and the recurrence of disease in survey was also pretty high. That is 26.6 and 23.4 in the patient who were diagnosed to have TB. So what was the inference? A considerable number of prevalent TB cases were contributed by a patient with the past history of TB. Hence, NT-EP needs close follow-up of patient completing treatment for early detection of recurrent TB and plan intervention for preventing recurrence of TB. So probably the infertile couple which we are getting, this is what I mean. As I say, latent TB is very common. Most of the people are already vaccinated with BCG. The bacilli is already dormant inside. So can it be a reactivation? Are we just missing something? Or just doing a Mantux or a TB gold or quantiferon is enough to diagnose it as a relapse of the TB? So why the recurrence occur? So as it is said, non-compliance is the first most important thing. Yes, taking these TB drugs, I mean 4 drugs at a time, sometimes it becomes very difficult. And many a times when patients find improvement, they tend to skip the doses. This is one very important challenge which we are facing. Not even in infertile patient, even in the patient who come with the history of yes, we have taken the ATT treatment. Jab deeply we ask them, then they say, madam, we took it for 2 months. Madam, there was some vomiting and there was some problems, so we didn't take it. Madam, I had some function in my family, so I didn't take it. So all these things really have to be grilled in their mind that compliance is very much necessary so that there is no resistance developing and there is no recurrence happening. Secondly, co-infection with HIV, which is common. Overcrowding, unhygienic living condition. Unhygienic living condition, I must say, I mean, when we were doing our MBBS study, during that time, my colleague, it's not that it is like we were living in a very crowded area, but still, because of the stress or maybe because of the work or whatever it is, she had cough. She was not eating well. And then her X-ray was done. She had a pleural effusion and there was TB. She was quite vaccinated. There was no abnormality detected before. So unhygienic living, and we really have a lot of cases if we come to know that whenever there is a stress, there is low immunity, then this dormant bacilli may come up. And not only this, it is so much so in the environment that if we go down on our immunity, then it catches up. It goes in the lungs, it stays there. From there, it spread through the bloodstream anywhere in the body. So that can be also the reason of genital tuberculosis in infertile patient and poverty and low socioeconomic groups. So what are the pregnancy outcomes after all modes of conception in patient with genital tuberculosis? So now we know that beautiful systematic analysis and meta-analysis done, and I have just taken the conclusion part of it. It says, like in early stages of GTB, when there is no noticeable damage to the reproductive organ, ATT alone suffices to pursue pregnancy without the need of ART intervention, as already told by Sir, that if it is detected early, given the treatment, then yes, we might not need the ART. Simple ovulation induction or even maybe IUI, or in the initial phases, if there is a blockage, a recannulation can also help this patient to conceive spontaneously. However, in cases when there is the disease has advanced and there is substantial tubal pathology, then IVF is the superior modality to achieve higher pregnancy rates. And as rightly said by Sir, When the endometrium is involved in different grading, it will have a different effect. So in grade 1, yes, she can conceive, but then the chances of implantation failure, spontaneous abortions, they are very high. And when even the basal lamina is damaged, there is a lot of Escherman, and the hysteroscopic finding is showing absolutely white appearance, multiple synechiae, treating those patients, doing metroplasty, and then starting them on TB, tubercular drug also might not be of help. And now the treatment of thin endometrium is a total different topic, and I have not included in this study. So because there are a lot of things which can be done, right from the metroplasty, then using ERP, even the stem. This is which says for fertility due to tubal blockage, IVF-ET is preferred approach. So even in IVF-ET, the impact of endometrial TB on fertility remains a concern because then the results are not favorable in those cases. So this is a Chinese study in which the pregnancy outcome after IVF in ICSI was done on 155 patients with GTB. They received successful anti-tubercular treatment, and the result showed that the pregnancy outcome in patient with tubal damage was not different to non-TB control. But in contrast, the patient who had endometrial TB, even after giving the successful ATT, they had reduced fertilization. Even the implantation rate was less, and even the cumulative pregnancy rate were less in those patients as compared to the non-TB patients. Again, Lee et al. Also compared 113 patients with endometrial TB after successful ATT treatment and 452 patients with non-tuberculous treatment. And what they found, even if the endometrium is not completely damaged, then also the cumulative live birth rate was significantly lower in these patients. And there is increased chances of spontaneous abortion rates. So the effect on endometrium for the tuberculosis is really varied. And we really have to be have a very deep acumen and a quick acumen to literally see, okay, if this patient is having a tubal blockade and still she is mensurating and you are finding a good endometrium, instead of wasting a time, it is better to start her on the treatment so that at least she can have some good outcome of it. This is a beautiful study done by Sir, Dr. J.B. Sharma, sir. It is a study only. It's not only the endometrium, it's not only the tubes which are affected, it does have an effect on the ovarian function. So it was done by Sir, in which he evaluated the effect of anti-tubercular therapy on the ovarian function, such as ovarian reserve, ovarian dimension, and ovarian stromal blood flow. 50 infertile women with female genital tuberculosis without TO mass diagnosed on positive acid fast bacilli culture or any granuloma or endometrial aspirate positive polymerase reaction, they are the one, as what Sir has told, the whole algorithm, those were taken up in these cases. And then these patients were started on ATP. And what it was found, these patients had lower ovarian reserves, and what was found that after the treatment of ATT, there was significant increase in AMH and the significant increase in the mean AFC of the patients. So even the effect of tuberculosis on the ovaries are something which we really have to look into our concept. And if treatment started on a proper time, then yes, still these things can be managed and can be saved. So this was a retro. Now, this is something which is really very confusing. As Sir also said, latent TB, as told by recommended by Government of India, we should not be treating until and unless we have other findings attached with it to start an ATT for these patients. So, but these are the few articles which I found about the latent tuberculosis, and these are the only ones which I really want to discuss. This was a retrospective analysis of the effect of latent tuberculosis infection on clinical pregnancy outcomes in vitro fertilization of fresh embryo transfer of infertile women. So what they have found that the clinical pregnancy rate in latent tuberculosis were significantly lower than non-latent tuberculosis group. But once the clinical pregnancy is postponed, significant difference in the live birth and the miscarriage rate in the two groups. So what they found, they said the logistic regression analysis showed that latent tuberculosis was an independent risk factor for decreased clinical pregnancy rate in infertile women undergoing IVF-ET. this is an article published in 2018, and it is being done by Pierre Girge. And why it is a very beautiful article, and it brings up a lot of controversies also, in which they have chosen the patient who were infertile, and this was the history which was taken: eumeroneric, oligomenorrheic, or normogonadotrophic women in the age of 21 to 38 were taken in these studies. Whether they are having primary or secondary infertility of more than 2 years were included in the studies. Their tubal patency was diagnosed on laparoscopy, either performed elsewhere within 2 years or during the course of treatment at the center. So these are those patients who had the tubal patency and still they were infertile. So what they did in these patients, they divided into two groups, group 1 and group 2. And in these patients, they took the endometrial sample and they had sent it for TB-PCR. And what was the result of that? In the one where TB-PCR was positive, they labeled it as the latent TB group. And in one, it was not positive. It was called non-tubercular or a group. So near about 395 and 380 patients were really put in both the groups. And what they have found that the women with latent tuberculosis were younger, and following the adjustment, they had significantly lower AMH and AFC, as what was done by Sir in his study and was Sir even told in the beginning. So what they did, the patients who came positive for the TB-PCR done on endometrium and with the patent tube and with the history of infertility and the menstrual irregularities, if they had, and even if they didn't have, they started all these patients on ATT. And after the course of ATT, when the ATT was finished, their IVF was done, and they found that the latent GTB yielded fewer oocytes, but they had more grade 1 embryo transfer and the better implantation rate in IVF compared to women in group 2. Group 1 had higher pregnancy rate compared to group 2. So probably once even they said if it is a latent tuberculosis and TB are positive and an infertile patient, giving an ATT to them will help them to have a better implantation. So these are two recent articles which caught my eye. One was correlation of female genital tuberculosis and infertility. This was done to know what we say the immunological factors and what are they? I mean, are they also the one which really play a role? So they say that GTB is mediated. It is a complex mechanism. The major mechanism involved induced are there could be immune dysregulation, altered secretion of growth factor and cytokinins, hormone similar disruption, reduced expression of cell adhesion molecules, and disrupted gene expression and signaling pathways. These mechanisms play a significant role in implantation failure and infertility outcome. So this is all done in the patient who really had latent TB. So this is a newer thing which is coming up. They say that delving deeper into the underlying mechanism, they identified that utilization of interferon gamma or nuclear receptors, which could revolutionize female GTB management and amplify women's prospects for successful conception and pregnancy. So besides the ATT, are there things which can be done? I mean, this is one thing which they are working. This is something which they are doing. This is not into the real practice, but all is that which is coming up now. And this is what is that changing trends in tubercular assault on reproduction. This is being published in 2014. And it says GTB is changing its way of assault to reproductive process, less by infection, but more by infestation of the genital tract, and thereby leading to harmful molecular changes or may be immunomodulation locally. So as we say that we live in the environment whereas there is so much of TB around, and the TB, we inhale it, it comes as a droplet, it can go inside, and lung is the favorite place because there is a lot of oxygen and it stays dormant because our immunity is very strong. But yes, from there it can spread around, and then some dormant bacteria can be sitting in the genital tract also. So that is what they call infestation. So is infestation also harmful, or do we really have to have a look of that? So what they said, they did an endometrial aspirate at mid-luteal phase, and samples of menstrual blood were collected, and it was sent for DNA PCR and cytokine analysis. They did it both. And what they found that the pro-inflammatory cytokines showed significant higher values in TB PCR positive patient than TB PCR negative groups. So probably even though it is dormant, there are some kind of immunomodulations which are going in. There are some kind of silent inflammation or infection which is still there, which is causing the infertility. So what they said that latent GTB infestation is responsible for unfavorable molecular changes in the reproductive tract and thereby causing a negative impact on the infertility. And this is one paper which I was discussing with Dr. Anuradha Khanna madam about her experience of treating patients who come with the complaint of genital tuberculosis and how she diagnosed and what she does.
Tina?
So this is what was her paper, in which she really mentioned about the diagnostic dilemma and the history and examination part, which is important, and the Mantoux and tuberculosis ELISA when it is positive and when it is negative, and then the leprohisto if the findings are there to start the ATT. So to conclude myself, before that, as we already know that yes, male tuberculosis, it's not very common, it's quite rare, but these are the few points which I really want everyone to know. Epididymis is the most favored site for the tubercular infection if it is present in male, and it can manifest as an acute infection, chronic infection, or even as the infertility. Testis is a rare site for tuberculosis involvement. One of the reasons for this is because of the blood-testis barriers. This may impede seeding of the testicular parenchyma. Tubercular infection of semen vesicle or prostate may be diffuse and result in aspermia without demonstrable obstruction of the ejaculatory ducts. These are the few key points like we should keep in our mind when we are really checking an infertile couple and looking into the female, and actually we should be taking a proper history from the male also, because we are endemic of tuberculosis, specifically the Uttar Pradesh area. Tuberculosis involvement of the penile shaft and the gland can result in severe disfigurement, ulceration, bulbous enlargement, though it is very rare, but yes, it can be a cause of the infertility. Primary aim is to treat by giving the anti-tubercular drug, but most of the time it presents so late that it might not show any improvement. And in majority of these cases, IVF ICSI can be the treatment of choice because most of them present with azoospermia because of the blockage. So to end this, I really want to say genital tuberculosis is a complex knot. The more we try to open, the more difficult it seems to resolve. MDT approach for management and diligent treatment while preventing the emergence of drug-resistant tuberculosis may provide an opportunity to improve reproductive outcomes. And having said that, I really want to put an open question to everyone, because probably maybe my experience is not that enough, and we are having here stalwarts to talk about the thing which Dr. Anu said. Many a times patients come to us when they have already taken ATT. And on inquiry, what was the reason of taking the ATT? They simply said that since there was infertility for 7-8 years, a Mantoux test was done or a TB interferon was done and it was positive, and we were started on the treatment. And even after the treatment, when they don't conceive, they come to us. So, sir, in these patients, if we divided, we found few of them had tubal blockade and few of them have nothing. So, to these patients who were already treated with ATT, who have already got ATT on the basis of Mantoux, on the basis of TB interferon, what is that we should proceed with? The algorithm in which we should be doing the leprohysteroscopy, and should these patients, if found positive, should be started on tuberculosis treatment? And yes, if it is yes, then it has to be done after consulting the tuberculosis specialist, because the resistance of the drug might be one of the reasons which we have to look for, and this is what we have to think of. So this is how I conclude my slides, putting up a question of a dilemma that whether TB interferon or Mantoux should be taken along with infertility as a sign to start ATT or not. So I really need the comments from our experts, Dr. Anuradha Khanna ma'am and JB sir, to really clear all the doubts for even for me and even for everyone else who are sitting here. Thank you, sir.
First of all, lots of congratulations, Dr. Ekika, to making this topic so clear from your side and also from our side. I am really very proud of you, and you
Thank you,
have
ma'am.
spoken very, very nicely, and especially to the topic that latent tuberculosis diagnosis and treatment. Really, it
Yes.
works a lot immune system, as I said in the beginning. So very nicely you have spoken, and it is mind opening. And regarding the TB Gold Plus, though it is not said nowadays by the India government interferon test that is, but 10 bacilli are there to cause this test positive. So, and that too are the active bacilli for the latent part, but they are not dead. So this is still important for me. So I usually get it done personally. I'm telling you that TB Gold Plus, yes, along with all other things which we are discussing, the history, the examination, the ultrasound finding before going to invasive test. As Dr. Kurana has done many markers of ultrasound. I really like it very much. And one more comment regarding the Kurdisac fluid you have mentioned. Whenever there is a Kurdisac fluid, again, it is a fluid which may be of tuberculosis, which may be of endometriosis, may be of both, because many laparoscopic thesis has been done in endometriosis and tuberculosis, and we find that Kurdisac fluid are having active macrophages. They are the starting of actually endometriosis. So we have always paralleled these two diseases, tuberculosis and endometriosis, in our mind, along with whole detailed history and examination. So a lot of congratulations, and your
Thank you.
things are so
Ma'am,
open to be discussed.
ma'am, can
Yeah.
I speak?
Sure.
Though she has asked Dr. Sharma, but I just wanted to put certain points here. Ma'am, as we have heard and learned from you, the main thing lies in the high index of suspicion. And while
Yeah.
doing Monto test or TB interferon gold, that comes as a part of that total scoring system where we are getting all the clinical symptoms which we are suspecting to be having tuberculosis, those soft markers on ultrasound, and sometimes that free fluid you are talking about. I'll give you few examples. A girl with secondary amenorrhea for 3 years, all the tests negative, nothing came positive. She's not responding to any treatment. And if her Montu can be done, she's not ready for undergoing diagnostic laparoscopy initially, and just on the basis of that Montu and TB interferon gold, we start ATT. That makes sense. Later on, when we do this laparoscopy, hysteroscopy, there was a lot of caseous material, as Dr. Sharma himself said, that comes negative for tuberculosis. Any test for genital tuberculosis is not perfect. Similarly, Montu is not always useless. If your all the symptoms and things are indicating, I'll tell you multiple laparoscopy findings for chronic pelvic fluid, free fluid in the cul sac. All the tests are negative. This patient is not conceiving, IVF failing, and after starting ATT, she conceives within 2 hours, 2 months or 3 months of therapy. What does it tell? That this latent tuberculosis behaves differently in different kind of population, and that depends from which area are we coming. We are sitting here, I was totally anti ATT person,
ATT.
but for last 5 years I got totally frustrated when a person was not ready for IVF, laparoscopy was negative, or she was not ready to, and looking at those signs, when we started ATT, she came pregnant within 6 months. So 90% of our patients where high index of suspicion is being used, ATT works very well. So it's not, you cannot just say कि gene expert सबसे अच्छा है या Montu सबसे खराब है. मेरी तो लाइफ में कभी जीन एक्सपर्ट पॉजिटिव ही नहीं आया किसी का. इतना इतना केसेस मेरे 2 पेशेंट डॉक्टर शर्मा के पास है अभी 2 लड़कियां मैम. दे आर 20 years old. They are drug resistant tuberculosis, as he rightly said. मैंने उनको सेकंड लाइन के लिए भेजा, इवन बीएचओ भेजा, माटा सर नहीं थे, किसी ने उनको हड़का के भेज दिया कि कुछ भी नहीं है, दे डोंट रिक्वायर एटीटी, तुमको गलत एटीटी चल रही है. They are being treated in AIMS now. So as we have learned the importance of Montu, I learned from Anuradha ma'am. And I still use it and it gives me, और मेरे साथ तो ये है कि ATT मैं जैसे चलाती हूँ, शायद वो लास्ट रिजॉर्ट मेरा पागलपन होता है, लेकिन अगर सही है तो वो पेशेंट प्रेग्नेंट हो जाती है.
Can I just interrupt and say that I think we need to be, first of all, fantastic talk, really well, really comprehensive. Seema, excellent points, very well taken. Anuradha ma'am, your expertise is great. We have all the seniors here, but I think what we also have to, for the audience, have very clear messages. It's anyway a confusing topic. So I think, Ekika, as you've said, when you are thinking of giving ATT, also be mindful of the impact it has on your ovaries. Be mindful of drug resistance. Be mindful that if you're going to give someone ATT for 6 months, now you tell me in your practice, a question to you, you started her on ATT. When would you plan her IVF if you have to? Would you do it in the 2nd month, 3rd month, 4th month, or wait 6 months? When you know someone, let's say in your patient who was advanced age, low ovarian reserve, you've given her ATT. So would you want to complete the 6 months and then start? Or would you say, okay, I give it to you for 2 months and then do? Because at the end of the day, it is a planned treatment. Your IVF should be given when you know the success is best. And what would be your take?
Yes,
It
Tanya,
will improve.
Tanya.
It will improve
very good.
AMH.
Yes,
As already mentioned by Kika, Dr. J.B. Sharma's paper, that
Yes.
after giving ATT
Yes.
6 months, the AMH is improved
Absolutely.
and her PI is treated. So it's very
And-
relevant. Once you have started, complete 6 months, then only
Yes.
go for it.
Yes,
I think
yes,
so.
yes.
For
One
the
more thing,
audience,
Tanya.
that's very important because sometimes what people do, they get impatient. Patient is
That's
impatient, so is the doctor. So they've started the ATT, and often you will see while they're on the AKT4, their treatment for IVF has already begun. So I think we must understand why we are giving them the ATT. What is the benefit that we will reap by completing the treatment if we started it, and then to give a treatment when you're going to optimize the outcome. My one question to you, Ekika, is when you spoke about men and semen, I think that's again a neglected area. How do you send the samples? Because that is something again which is not done correctly. And I think if we have a lot of junior audience, for them to know, how do you tell a guy? Should they just pitch up to a lab? As Sir said, it's also important who does the test. The pickup is important. We are very good with women. We are not so good with men. So if just a word of wisdom for the audience, for men.
So, Tanya, there are two things which I really want to talk about. First of all, you said when you start an ATT, when you start the treatment. So I say we don't start and after at our center once we are done with 6-month treatment. It is not that there are times, when you start the treatment, they really have an improvement in symptoms. If it is because of tuberculosis, soon they will start having an improvement in symptoms. But we have to keep in mind that if we start the treatment and if she becomes pregnant, sometimes they don't take the treatment completely. So that is what even Sir said, that during the treatment also, I mean, this is again will be in a group where there is no damage to the tube and there is a damage to the tube. Sometimes they conceive themselves starting the treatment, so they have to be advised to continue the treatment. So as such, at our centers, we don't do it till the time we complete the 6 month of treatment. If because of anything, even in the advanced stage, if everything is fine, see, tuberculosis will never prevent a pregnancy. We see patients with active TB who are pregnant, getting pregnant. So once you start the
Even
treatment, if they
miliary
get
ones.
yes,
Absolutely.
yes, even the miliary ones. So even if they get pregnant, even in the advanced cases, there are chances that they will get pregnant. So they should not. The main
Stop the
thing is,
treatment, yes.
important key message is they should not stop the treatment for 6 months at least. And as
One
far
thing
as
more,
the
Ekika, that the immunity is down-regulated during pregnancy. So if you will
Yes.
stop it,
Yes.
TB will be flared.
Flared up,
So
yes.
on
Yes.
this
Very
you have
important
to
key
complete.
point.
Yes.
One more thing
Absolutely,
also,
ma'am.
I have seen a case with the congenital tuberculosis in the fetus, and then
Yeah, it has been
intrauterine
reported also, ma'am.
That's been
Yes,
reported.
yes, they have reported. And then in the X-ray of the baby, there was miliary tuberculosis. And the patient actually, in that case, patient had miliary tuberculosis, and the baby has got the tuberculosis, but someone has said stop ATT, and she stopped ATT, and the result was this.
Tanya,
So we
second
should
thing, if
continue.
the ovarian reserve is lesser, we have to tell the audience if her AMH is 1 or less than 1, 2 months of ATT takes care of killing almost all the bacteria. So if we are in that kind of desperate situation, we can collect her oocyte after 3 months of ATT only in
Freeze them.
desperate situations, not otherwise. Otherwise, she has
Absolutely.
to undergo 6 months of the treatment. And second thing, the immunomodulator role of ATT in latent tuberculosis, which is being talked about a lot. Dr. Firoza Parekh was talking about it in ISAR. It was being received very nicely, and people were asking so many questions 2-3 years back when we were there. So this is also something. Only thing is, just on the basis of Montu or your pregnancy failed or you just got implantation failure, next time you have to give 3 months of ATT. That is becoming very prevalent,
Very
especially in
common.
North
Yeah,
India. They are giving 3 months of ATT and then they are planning embryo transfer for IVF patient. That is not the way. And we have to
absolutely.
come up with that scoring system. And first
Yeah,
of all, you have to, and that patient in most of the cases, her body will keep telling you. She'll start losing weight if you are not being careful. She'll not able to tolerate it. Otherwise, most of the people, they tolerate ATT, their weight increase, their other things increase. So we have to keep our eyes open, and it is a big decision and ethical responsibility and moral responsibility as physician to make someone undergo ATT. So please be very, very careful while starting it.
absolutely agree, Seema.
Seema,
Especially in
So can
RIF cases, I think what people are
yes,
doing, as you said, because of the immunomodulatory, Ekika, I'll let you say, when nothing they
yeah,
understand, they give ATT 3 months. We've had so many patients, they've
that's what
taken
they call
ATT for 3 months, they've stopped it, and then they come to you and say, now let's do the IVF. So I think the key point,
it.
Ekika, why don't you take it forward?
So
Can
that's like I want to say
can I
empirical.
mention one thing?
Yes, please,
Please,
Dr.
ma'am. Yes,
Hi.
please.
So
Hi.
it's
Hi.
hi, hello. I'm Dr. Suparna. Fantastic talk, Ekika. So in a peripheral clinic, I have seen patient
Yes,
male
are you
tuberculosis
partial
when
ATT?
we are male tuberculosis when we are talking. The patient was azoospermic and went to numerous urologists, and he was being treated for any infection. Numerous antibiotic been given, and he had a symptom of scrotal discharge. And when he came, and surprisingly, after 4 or 5 urologists, it was I diagnosed the tuberculosis for him. And then after the ATD treatment, completely the discharge is gone. Scrotum is normal, though the spermatic cord got obstructed. So he is now obstructive azoospermia, but we retrieved sperm by TISA. So IVF prospect is there. So unfortunately, sometimes with we think that so many expert has seen already been excluded. So sometimes it's not excluded. Some simple things are missing. So we can improve the chance by if we think and reasonably take the history and proper. If we miss something, and that will be a big miss for that patient.
Dr.
So
Suparna, how did you
Sorry to
diagnose?
interrupt. Sorry to interrupt. Our panel is waiting.
Male infertility, male
This has
tuberculosis.
become a panel only. Sorry. Agreed, Dr. Anu. I think
Actually, our panel is waiting. I'm so
Excellent
sorry.
talk,
Actually, it's
Ekika,
a
and
beautiful, it's a
thank you.
wonderful topic, and we can discuss it whole day and whole night.
Whole day. Yes, of
Thank
course.
you, Anu. Thank you,
I just
Fezzi,
want
and
to end with
excellent
few
talk,
things, few
Ekika.
wordings.
Thank you. Thank you.
Thank you, Dee. So
Thank
just to
you.
end, as
Thanks a
Anya
lot.
said, empirical treatment is a big no. Just kindly sit, as Sir said, confirmatory, probable, and possible. These are the three things we should look for.
On
And yes, on
clinical
this
ground,
basis, we can
empirical
start.
word is gone.
Yes, empirical work is not confirmatory, probable, or possible. This is how we have to change our terminology. And second thing, we really have to think of the male partner also. That I think
How to diagnose him.
you are absolutely right. I know it's a very big topic. We'll be talking.
Yes, it's
Thank
a
you
big
very much,
topic, and we
everyone.
can discuss it on and on.
Yes, thank you. Thank
Dr.
you. Thank you.
Sangeeta, stop sharing. We have to introduce this panel.
Sorry, Sangeeta, we took a lot of time. We'll not.
No, ma'am. It's okay. You already set the stage on fires. So it will be a good
So
discussion.
you'll enjoy
So,
good
I'm
discussion
waiting for
now.
that.
Yes.
can you, Dr. Anu, can you introduce?
Yeah. So coming to a panel discussion, much awaited panel discussion, and our moderator is Dr. Sangeeta Rai. Kindly display her CV. First of all, she is my good friend. She's professor and head of the Department of Obs and Gynae, IMS BHU. And she has 50 plus peer-reviewed publications, and her research interest in endometriosis, female infertility, PCOS, preterm birth. She is co-author of book chapters on PCOS, endometriosis, PROM, HIV in labor. So, and she has won Superhero Award and appreciation from Foxy, UNICEF, Safe Motherhood Committee. Welcome, Dr. Sangeeta.
Thank
And
you so
would you
much.
like to invite
Anu.
your panelist, Dr. Sangeeta?
Yeah, I will welcome my panelist. So thank you so much, Dr. Anu, Dr. Facey Lewis, sir, for having me here. And it is a very, very important panel discussion because the infertility and the diagnosis of tuberculosis is very, very important because if you don't diagnose this in the early stage, the latent period, we lost the patient because whatever you do, the patient will not be able to conceive. Okay, it will be resistant. So with the 2 or 3 cases, I will be discussing and carrying the panel. Please stop sharing the screen.
Can you introduce the panel members?
Yeah, I have 4 beautiful panelists. Dr. Sakshi Agrawal, she is associate professor in IMS BHU. Dr. Pradashni, she is also a very intelligent and very active member of Vox. And also she was a senior resident from our IMS BHU. And presently she is a lecturer in Mirzapur Medical College. So welcome, Pradashni. And the other panelist is Dr. Srilata Gaurti, and she is basically a medical director at Revive Clinic and Fertility Center, and she is a consultant gynecologist and reproductive medicine specialist. Welcome, Dr. Gaurti. She has many achievements. And Dr. Surya Malik, she is an infertility specialist along with high-risk pregnancy, and she is basically presently as director and consultant at Jaspal India IVF Center, Ambala. So we have IVF specialist also over here. So welcome all of you to this panel. Thank you.
Thank you, ma'am. Thank you, ma'am. Thank you.
So let me share the screen because I don't want to be late. So let it start discussing the questions. We all know that the prevalence of tuberculosis is increasing, and after the COVID, the WHO has proposed a study that there's a decrease in 25% detection rate of tuberculosis. So more cases of TB we are seeing because of the poor detection rate. Epidemiology, we know that it is a significant cause of morbidity in the women, particularly affecting the fertility, which is responsible for at least 1% of all the gynecological admissions in India. And among the women with infertility, the incidence of female genital tuberculosis range for 6 to 25% in India, and higher prevalence is reported from tertiary care centers and in ART centers. So it is more common in the younger women compared to elderly in developed countries. A 5-fold increase in TB incidence is observed in countries with a high HIV prevalence due to immunosuppression, and female genital tuberculosis is seen in 30% of the sputum positive pulmonary TB cases and 10% of the extrapulmonary TB cases. We all know that primarily it is by the Mycobacterium tuberculosis infection due to aerosol inhalation, and it becomes latent. But if the immunity is suppressed, there is a reactivation, and further there will be hematogenous spread to the female genital organs. Sometimes there may be indirect spread due to ingestion of the unpasteurized milk by Mycobacterium bovis, and from the bowel, it directly affects either the peritoneal cavity and the oocytes. And the least and the rare is the intercourse with the male partner, which is suffering from tuberculosis. So we all know the primary focus is the lung and the female genital organs, especially the fallopian tubes, the ovaries, endometrium. They are one of the most common site of the extrapulmonary tuberculosis along with the bones and the joints. So the most important thing is the precise incidence is difficult to estimate because there is always an underreporting, vague symptoms presented by the patient. There is absence of highly sensitive single diagnostic test, and there are multiple coexistent infections. So high degree of suspicion along with the multiple parameters is crucial to detect the disease, and the treatment of the latent infection is important. Otherwise, there may be a permanent sequelae in the form of infertility and amenorrhea and premature ovarian failure. So I welcome my 4 panelists for this beautiful panel discussion. So to start with, we have a Mrs. X. She is 18 years younger. She come to my OPD with a complaint of primary amenorrhea. She is educated till 10th standard. She is a Hindu by religion. Can you, yeah. She has only history of primary amenorrhea. There is no complaint of any loss of appetite, loss of weight, or irregular bowel and bladder habits. No history of drug intake, no history of any surgery or TB in the family, no history of sexual contact, and no abdominal pain, cyclical abdominal pain especially, and no history of surgery. In the family history, no history of any chronic illness in the members and similar complaint in any other siblings. Personal history is nothing significant and there is no history of substance abuse. On general examination, nurse is quite well-oriented, conscious and well-built. Height is 160 centimeter, afebrile, and her vitals were normal. All the systemic examinations were normal. Coming to the Tanner staging, because we thought that she is a case of primary amenorrhea, she is 18 years, so we did the Tanner staging, and breast examination was a stage 4. Her pubic hair examination is stage 3, and axillary hair was also stage 3. Performed abdominal examination, which was normal, soft on palpation. There is no palpable mass. There is no pain or tenderness. So, to any of the panelists, what are the symptoms of this girl where we can raise a suspicion that she may have a genital tuberculosis, or what are the other questions we can ask to this girl? Any of the panelists?
Ma'am, first is the primary amenorrhea was a main common symptom that she has presented. She was not having any general symptoms of anorexia, weight loss. The symptoms was only the menstrual symptoms that was present was a primary amenorrhea in this girl.
Any other thing you want to ask her?
She doesn't have any symptom, generalized symptom. You have written that no weight loss, no nothing like that.
So this patient doesn't present. So 10% of the patient may not have any symptoms. So primary amenorrhea may be due to some genetic Mullerian abnormality or maybe due to Turner's. Okay. So because of this, we did the Tanner staging. So how will you go for further intervention in this girl?
See, still we will like to do the hormones for her because still we have not made the diagnosis of tuberculosis for her, ma'am. So still we will get through the hormones, appendage, prolactin, these hormones to be done. And basically,
an ultrasound examination. Yes,
ultrasound examination, definitely we have to look into the ovaries. So on these, calculated findings, we'll be able to detect that what is the problem. Why the female is having the amenorrhea.
So that is very much important. We should not jump onto the tuberculosis, yes? Because primary amenorrhea, there are many causes of primary amenorrhea in a young girl. So ask for all the history taking. We have taken the history very nicely, and then we investigate by general physical examination and the pelvic examination. So abdominal examination was normal and pelvic examination was also grossly normal. We didn't do the PV examination in these girls. Okay. So the family history was not very significant. Her chest examination, her bimetal examination, we didn't do in this girl. And PR examination, we have done, but we don't find any gross abnormality. So as you said, that we have to go for the general investigations like the day 2 LH-FSH because she is not menstruating. So just we go for the serum prolactin and serum thyroid level, which is normal. What are the rest of the test? Because the test is very much important. As you said that the baseline investigation of tuberculosis, we have to see whether the patient is having leukocytosis with lymphocytosis or there is a chest X-ray to confirm or exclude pulmonary tuberculosis. Tuberculin test, Montu test, it is very, very rare, not done nowadays. And I have you seen that lot of controversy in Montu test, but yes, we can do to see whether the patient is a case of latent tuberculosis or history of any latent infection. And then whatever you plan is the ultrasound. Okay. So in ultrasound, you suggest that, yes, madam, I will go for the ultrasound. Yes, in this girl. So what are the ultrasound finding which may give rise to suspicion of tuberculosis in this girl?
They can be TO-mass, tubovarian mass.
TO-masses are the most common ones. And ma'am, and on looking in the endometrium, we can see for the blood supply in the endometrium also, no? The Doppler flows, if we can see the endometrium must maybe having the poor blood flow in these type of patients.
So
Thin
this
endometrium.
is a young girl. You are doing the ultrasound whole abdomen.
Ultrasound. Whole abdomen, yes.
It is,
ma'am.
it is very difficult to
Ma'am,
elucidate.
TO-mass I think is the most common presenting.
So these are the list of the findings where you have to suspect if there's a persistent thin endometrium, chronic PID case, fluid in the endometrial cavity, calcification in the endometrium, encysted ascites or hydrosalpinx or restricted mobility. Okay? So these things you need to see very nicely in these patients, and then you have to go for, but in this girl, everything was normal. The ultrasound was grossly normal. Okay. So we have to go for the specific investigation, as I have said, and then MRI. So any role of MRI? Should we go for MRI if ultrasound is normal in this girl? Do you think that it is important, MRI or CT? What is your message?
Ma'am, I think it is important because to rule out MRKH, when to look for any other things, MRI can be done for the cases of primary amenorrhea.
Ectopic kidney can be ruled out.
Yes. So because especially if there's a suspicion of any Mullerian abnormality or endometriosis, in that case you can go, or otherwise if you want ultrasonography, if there is a bilateral tubovarian mass, then we can go for MRI. Otherwise, MRI should not be done in every patient. So what is the further plan of management? Ultrasound was normal, you have done the baseline investigations which was normal, then how will you plan? She is a case of primary amenorrhea.
We'll give her a estrogen progesterone challenge test.
Yeah, very good. So because you have to let the patient bleed. So in her case, we did first the progesterone challenge test and there was no response. And then we gave estrogen and progesterone challenges and again, there was no response. So how will you proceed?
So now we have come to know that the problem is in the uterus. Because,
yeah. So endometrium is not receptive.
Yeah.
The endometrium is.
So what you will do?
So the middle hormone profile. It was stable. We still.
So what hormone profile you will do?
Sorry, Sangeet. Hormone profile. And we'll do FSH for her.
So we'll go for FSH LH?
FSH we'll do specifically, madam, and FSH if it is less, then it will be, and the second, and we also have to see the secondary sexual characteristics of this girl. And if it is less, then we can think of hypogonadotropic hypogonadism. And if it is more, like more than 50 and in menopausal range, so hypergonadotropic hypogonadism can be suspect. And also, ma'am, karyotyping can be done for this patient.
Very good. So we did the karyotyping and FSH LH and it was hypogonadism. Okay. That is basically the patient which is presenting with the Mullerian abnormality. We have to go for the chromosomal abnormality. So we did suspect and it was normal and it was a hypothalamic suppression. Okay. So FSH and LH was low in her case. So what you will do further? Because her worry is that she is not bleeding. She is 18 years. So what
outflow of ma'am, if ultrasound is
MRI was normal. Ultrasound was normal. So we did the MRI also. There was no cyclical pain. So there is no Mullerian abnormality in her case.
So ma'am, in such cases, then we should go for diagnostic laparoscopy.
Yeah. So this is one of the best intervention because all the tests, they are negative. So in her case, we counsel the patient and take the consent for diagnostic laparoscopy and hysteroscopy in her case.
Yes,
and all the specific tests we are sent after going for diagnostic laparoscopy and hysteroscopy. And what we found that during the hysteroscopy, we have a thin endometrium, very pale endometrium. And we take the sample and we send for all these tests. So I will ask any of the panelists, when you take the endometrial sample, whether you take the premenstrual blood or postmenstrual blood. In her case, she is not bleeding, so you have to take the endometrium. Yes. So generally, if the patient is menstruating and you need to send the blood for the sampling, then what are the phase of the endometrial cycle you prefer? That is premenstrual or postmenstrual?
Premenstrual.
So why? What is the reason?
Ma'am, because the tubercular bacilli will be sitting on the top superficial layer of the endometrium. So when we take the scrapings, so that will come. Otherwise, if the endometrium is shed, if we take it in the post-menstrual cycle, so we will miss out with the tubercular bacilli.
Yeah, very nicely explained, because it is very much important that these patients should be called premenstrually. Okay, that is important. But if she is not bleeding, we take the endometrium and we have taken the endometrium and sent for these specific tests. So can some of you will elaborate that in your practice, you send the endometrial sampling for all these tests or some few tests? What is your take-home message? Yeah.
We do tests. I test for AFB and PCR. Mostly AFB have not seen so far come positive. PCR has come back. I mean, I've been in UK for 15 years. I've never seen it there. 10 years in India, PCR in the last 10 years of practice, I got positive for 4. Then to actually take it further, I took the opinion of the TB specialist. It's a multidisciplinary, as we said, because I didn't know what it was. He analyzed those 4 patients further. 2 patients were put on anti-tubercular treatment, after which the endometrium thickened and improved. 2 patients, actually, he didn't do anything. He said they didn't need treatment. They kept on having modalities of treatment. And the other 2 who were not treated went on to have IVF and had pregnancies.
Okay. And what about others?
Ma'am, I would like to send for microscopic and staining, for the culture, for the CB NAT, and for the histopathology.
Yes. Yes. So it is very much important, because depending upon the clinical symptoms, you can't start the ATT. So at least 5 investigations you have to do along with the history taking. If the history taking, it is a strong suspicion, then in the investigations, you have at least either AFB culture positive or CBNAT positive, or there is a histopathology finding of tubercular granuloma. Okay, because on the basis of the PCR, you cannot start ATT therapy. You can suspect.
No.
So if the PCR is only positive, then you can go for laparoscopy and hysteroscopy. Yes.
Yes,
Because
ma'am.
endoscopy
Just now, JB
procedures,
Sharma
yes.
sir
False
told this
positive
thing.
Yes.
also.
It is very much important. So these are important tests, and because they are very costly tests. So we need to understand the utility of this in the clinical practice. And we are before the introduction of BACTEC, we usually go for the LJ media, Winston Jensen culture media, and it is very sensitive and specific, but it takes 6 weeks, long time. So with the advent of the BACTEC technology, it is a quicker results. Okay, it gives results in 5 to 10 days with good sensitivity and specificity. So it is a very good test. And along with the CBNAT, it is a gene expert where we can go for the detection of the mutation too. It can replace the need of the culture and the smear, and it can detect as low as 133
Sangeeta, may I interrupt?
hits. Yes, madam. Sure.
Actually, the LJ or Lorentz-Stein method, you need 1,000 bacilli or more than 100 bacilli.
Yes, madam.
But for this BACTEC test, you need only 10 bacilli.
10 bacilli.
So that is the main reason. Because if it is an active disease, you may get it. But if it is not active, because the thesis is already done in BHU and the things were not, the gene expert was positive only in one case, in which she had cocoon in the abdomen.
Yes.
But the advantage of gene expert is if it is positive, you will get the sensitivity of the drugs.
Yes.
Which drugs should be given most. And I had total 3 cases gene expert positive throughout that period.
But
and all the 3 had rifampicin resistance.
Yes.
So this is very important.
We need to understand.
Though it has come in guideline,
yes,
but it is of not much use, what I will say. And BACTEC, yes, that's why I'm still going to have TB Gold, because though it is latent TB, and already we have discussed with Dr. J.V. Sharma and Nikika why it is important. Yeah, please go ahead.
Thank you, ma'am.
Thank you.
So again, madam has said that PCR, it is very much important that when to do PCR. We are sending the PCR method to diagnose the female genital tuberculosis infection, active infection, but we should not start because it may be high false positive and false negative. So in the clinical practice, we
Very
need to go
sensitive.
for endoscopic techniques, okay, to start the ADT therapy. So in this girl, we did the endoscopy, okay, laparoscopy and hysteroscopy. So what are the findings in endoscopy in this girl? You can find.
It can be cages, nodules. We can see the
tubercules can be seen, cages, nodules can be seen, adhesions can be seen, ma'am.
Ma'am, teomases, adhesions, tubercles,
cystitis.
Just I want to ask one line that for diagnosing a case of tuberculosis, do you go for laparoscopic intervention in every case?
No need.
No. Yes, that is very much important message. Laparoscopy should be done only when rest of the investigations are normal. Okay, and still you have a dilemma. So in that case, you have to put the laparoscope and then you can see, as Dr. Pradeshni has said, caseous nodules, shaggy areas, adhesions, tubular masses, encysted fluid collection, hydrosalpinx or pyosalpinx. So this gives a picture and you can collect the sample also directly in these cases. So this is a laparoscopic finding of tubercular patients if you are going with the tubercular diagnosis, and these help us to diagnose, and if this suspicion and one of the histopathological findings, you can start the ATT therapy. Coming to the role of hysteroscopy. So what is the role of hysteroscopy in identifying tuberculosis?
See the endometrium. How is the endometrium? Is it pale? Is it has got some tubercles on the endometrium, and these things to be noted. Like when
and cavity may have adhesions, distorted cavity and obliterated ostia can also be seen.
Can be there.
In fact, it's
Grapefruit.
probably the most important investigations, because if we have the other STIs like chlamydia and gonorrhea, they don't really affect the uterine cavity. This is something that wrecks the cavity, and I think a thin endometrium, fluid in the cavity, these are very frustrating when we are doing fertility treatment. So I think hysteroscopy is very important to look into the cavity, diagnose, take a sample from there, and then treat accordingly.
So in this girl, basically we did the hysteroscopy and you can see there's a pale endometrium and there's a lot of adhesions in this patient. So we can get spotted endometrium or pinhole ostium, periosteal fibrosis. The cavity may be narrow, there may be caseation or scarring, and then we take the sample for the TB-PCR and histopathological examinations. And when we did see the result, it was a granulomatous endometritis. Classical picture of granulomatous endometritis in this girl. And then we started her on ATT. So can you tell me what is the course of the therapy in this girl?
Ma'am, 2 IHR-ZE plus 4 HRE.
So this
6
is
months
the
of treatment.
first 2 months and next 4 months. Okay.
Next 4 months.
drugs and the 3 drugs. And depending upon the body weight, we have to start the AKT4 and AKT3. And surprisingly, just after 1 month of ATT treatment, the patient started having normal menstrual cycle. And she was very happy and she came to us. So that was a miracle for her, because she was struggling with her menses and all the investigations, but there was no output. So genital tuberculosis is a disease of the young girl, with 80 to 90% of the patient being first diagnosed between the age of 20 to 40 years, especially in developing countries. And the TB control program, India achieved a high success of 71% detection rate and 87% success rate, with 7-fold reduction in the death rate in all the cases of TB, including female genital tuberculosis. So what we learned the lesson here, a high index of suspicion needed for diagnosis, which include personal history, family history, or any history of ADT therapy, because this can cause permanent damage to the female genital tract in advanced stages. So we have to be more vigorous, okay, to detect this disease. Because early diagnosis and treatment in subclinical stage can prevent permanent damage and sequelae of female genital tract tuberculosis with successful pregnancy outcome. So coming to my next case.
Just an interference. In
Yeah.
between, I was not here. What was the hormonal profile in this case?
It was, ma'am, suppression of LH and FSH. Both were low. Thyroid was normal.
So that means tuberculosis was having
Suspected.
gonadotoxic effect.
Yeah.
Was prolactin was raised?
No, it was normal.
No. Because this also, and there's also condition in which because of tubercular meningitis, also it will go to the hypophyte.
Yes.
So past history of childhood history of tuberculosis is also very important in such cases.
Very
Have
important.
you given
Thank you,
a
ma'am.
withdrawal bleeding like giving estrogen and then
Yes,
progesterone
madam.
in this
She
case?
didn't respond. Both to
Didn't
progesterone and estrogen.
Yeah.
So
Okay,
that's
thank
why
you.
we have taken her for lapro and hysteroscopy.
Okay, thank you.
Thank you, madam. So in my next case, she is a patient of 23 years, nulliparous, married for 3 years with regular stay with the husband, presenting with primary infertility. Her menstrual cycle was irregular, 40 to 50 days with average flow. How will you proceed now? She is coming with you with the primary infertility.
First test a specimen, husband's sperm.
So you will jump only for testing the husband's semen, nothing else.
First, yeah,
We'll
fertility
take a
specialist.
proper history
First
and
husband,
examination
only
of the
then the girl.
patient.
As a cycles
First
are
of all,
irregular, so we have
Fertility, if
to.
they come first, is husband always. That may make the woman happy also.
and we'll take a proper history also, and
Yeah,
we'll
let's
see
see,
whether
of
they
course.
have enough knowledge about the fertile days or not.
But her cycles are irregular.
40 to 50 days. Yeah.
Yes.
Delayed cycle.
Delayed cycles are
We'll do a scan, ultrasound, hormonal
Yeah.
profile,
Physical examination
routine
of the
ones.
We
patient.
did
Yeah.
her ovarian reserve test, which was normal. Our transvaginal ultrasound, the uterus was retroverted with grossly normal adenixa. Her male factor was normal. Here I want to ask you, all of you, whether you go for HSG in her case. What
Not
you
in the
do,
first go. If she has got irregular cycles, I would like to try ovulation induction first for a few cycles before going for HSG.
But already she is a 3 years case of primary infertility. So
Yeah,
without
but she
seeing
has
the
irregular
fetal
cycles.
status, because whether she is
Sorry?
ovulating, because you have to think that the tube is okay or not before going for
Yes, it's
induction.
right. But normally when the patient comes with irregular cycles, maybe at least 2-3 cycles of ovulation induction to see if she's actually ovulating, because irregular cycles she may not be ovulating. So we correct the general lifestyle factors if she's overweight, exercise, things like that, and hormonal profile to rule out PCOD or diminished
So it
ovarian
is
reserve. But you
normal.
said it's
It is
normal.
already,
It is normal.
This is normal.
So yes, we'll discuss with the patient, but I would probably go for ovulation induction before going for HSG.
Any other
3
panelists?
cycles at
Any
least.
other?
Ma'am, I would like to go for HSG
Yeah.
together, because if tubes are blocked, even though we are trying for ovulation induction, she may
work.
not conceive.
It will not work. And
But-
since three years have elapsed, so better
Yes,
to go for HSG. Yes, that is important.
better.
But she's very young and she has a regular cycle. So I think depends on how we counsel the patient.
So in
But
this
yeah,
patients, we
this
go for hysteroscopy. We didn't jump
yes.
for HSG because she has abnormal uterine bleeding. So we
Okay.
go for hysteroscopic evaluation
That's the
of the
right thing, yeah.
endometrium. That is very much important. And there was a classical pattern of suspicion of tuberculosis, because there are many papers which are coming up that did hysteroscopic mapping can replace or correlate with the histopathological or serological test. And it is very, very sensitive, because if you are doing an experience and you are doing a hysteroscopic mapping of the endometrium, you can detect the tuberculosis by your findings with the classical appearance which is proposed. So we go for the test, and gene export was positive and HP was endometritis. So here I just want to say that if there is a suspicion of tuberculosis in the mind, we should not jump onto the HSG, because
Dr.
active
Sangeeta,
tuberculosis may clear up.
It can disseminate, yes.
Yeah.
What about her ultrasound finding?
It was normal,
It's
ma'am.
normal, I
Your
think.
uterus was
It's normal.
retroverted. Nothing
No,
else.
And
that is
endometrium was not
that
thick
is a
or
warning.
thin or anything.
If you are
Endometrium was
getting,
normal.
if you are getting a retroverted uterus, that may be adhesions in the curly sac because of the tuberculosis.
Tuberculosis, yeah.
And
It
then
was a
we have
suspicion.
to assess her endometrial lining, the
Yeah,
irregularity, the nodularity, the zone flow, so many things, because you are getting very typical histopathological finding of granulomas, and with the high power density ultrasound, that which is a non-invasive tool, we can avoid
hysteroscopy, yes.
we can
And
go
ma'am,
for
in this
hysteroscopy,
retroverted,
but
sorry, in this
this high
retroverted
power
uterus, maybe
Doppler
she,
sonography is very good in such cases.
yes. And in
Because she's
retroverted
married, you can put a TVS, you can have a zone flow, you can have color Doppler, so they are additive.
But
and in
we
this
need to have a
retroverted uterus,
surgical test, madam. We need to collect the endometrium.
yes,
If
she could have
it's
dyspareunia in this
tuberculosis.
case. In
So
retroverted
that's
scarred,
why
if she could have,
hysteroscopy is very helpful, madam, because the tuberculosis, we can see the cavitation in the endometrium. We have many findings and we can take the sample also. So blind
Why I'm
PNC
saying,
can
Sangeeta,
replace
because this is an invasive tool.
Yes.
Hysteroscopy is an invasive tool. If you are getting a good guidance by a non-invasive tool like ultrasound with Doppler, this will be useful. And then she is menstruating. Why not to have her menstrual blood to go for PCR in such case? Though you are okay to
It
say
is
that
already a
now
debate,
studies
madam,
are coming,
married
but
patient,
just
whether you go for menstrual blood or TB PCR of endometrium, again, it will
this
be
TB
debate,
PCR
madam.
is not very costly.
Yeah.
2,500.
25 only.
And less than TB gold.
Yes. So here we are going for the histopathological examination, madam, and we are seeing the granuloma. So it is
It's
100%
okay. I'm not saying you will
diagnostic.
not get the finding. I'm
Yeah.
just saying non-invasive tool is superior to invasive tool. I'm not saying
yes, ma'am,
that
I
you
do
have done a
totally
wrong
agree.
thing, but I'm saying first you go for a more detailed non-invasive tool. That's all.
Yeah. So on
Can
the
I
basis
just
of
ask?
PVS,
Sorry.
can we start ATT, madam?
Can I just
Yeah,
ask you,
if you're
sorry,
getting.
Yes.
sorry to
Dr.
interrupt.
Mia.
You've done a hysteroscopy, and the question was about the tubes. And as Anuradha ma'am said, you've put somebody under an invasive test, and you're looking at an infertile patient. Was there a reason you didn't want to do a lapro along with the hystro, and
Both.
you just thought of a hystro alone?
Leprohysteroscopy.
What
Yeah.
I
It
mean,
should be leprohysteroscopy.
Rightly said. Actually, the patient doesn't want a laparoscopy here. Ideally, it will be laprohysteroscopy.
yeah,
It's
because
not
if
very
you're
Ultrasound
going
was
good.
to
normal. There
evaluate
was
an
no
infertile
tubo-ovarian mass.
patient,
No, there was no tubo-ovarian mass, just a retroverted
MRI was also
uterus.
normal.
There was a suspicion only because retroverted
but there
uterus
wasn't
was there.
anything on the ultrasounds as well. So as Anuradha ma'am has
No,
said, if
there
you're going
was
to
no
take
collection.
someone,
There was no collection. There was no
so if
collection. Endometrium
correct, so
was
there was nothing
normal.
really on ultrasound
Yeah.
or on ultrasound,
Yeah.
blood parameters, hormone parameters,
Yeah.
semen. The only thing that you got were irregular cycles with 3
Yeah.
years of infertility.
Yeah.
So probably if you're going to evaluate someone, then a complete evaluation would be a lapro with a hystro. I mean, if you're going to do a test, but okay, fair enough. If the patient did not want a laparoscopy, but I guess it would have been offered to her to have a complete evaluation.
Yeah, that is a good thing because laparoscopy will give more detailed study of the tube and we can go for the tubal patency test also. So that is one of the best. Here because I am asking for HSG. So
Right.
HSG because there is a more invasive procedure like
Yes.
hysteroscopy and there is a chemical thing you are inserting. So it can flare up. So that is why we are preferring lapro and hysteroscopy in these cases. But in her
Yes.
case, because she didn't want lapro.
And Dr.
thank you.
Sangeeta, anything in her
Rule out
history
any
that
other pathology.
that made you feel that she could have TB, like dyspareunia or a raised ESR or something?
No, it
that
was
made you
just for
suspect.
abnormal uterine bleeding, irregular cycle.
Hmm.
We just put her on for hysteroscope.
Right.
There was no
Your
suspicion of
indication
TB
was AUB.
just by the symptoms. It's just for abnormal uterine bleeding. We put her for hysteroscopy. Nothing else, and just we found this type of classical picture, and we get this. So after the diagnosis, we see that this is a report. We come up with the granulomatous endometritis and this positive for Mycobacterium tuberculosis, the sample. So we started her on ATT and after the ATT complete 6 months of treatment, patient come for infertility. We told the patient not to get conceived And after 6 months, she come for infertility, and we did again the ovarian reserve test along with the TVS in detail. The endometrium flow was not very good. On the day 12 of the TVS, ET was less than 6 millimeter endometrium with poor vascularity. AMH was 1.78. Male factor was normal. And now we did the HSG and it was normal because patient doesn't want laparoscopy, as I have said already. So how will you plan? Again, for infertility, she presented with infertility with less than 6 endometrium. So what is thin endometrium? As Dr. Akika was saying, that thin endometrium is much more common in this patient with general tuberculosis, and it is a great dilemma how to treat this thin endometrium, because when we go for IVF, the chance of implantation failure. So to any of the panelists, how will you go for thin endometrium treatment, and how the general TB affect the fertility?
Of course, the TB might have affected her endometrium. It's actually pretty difficult to treat. We can try the other things such as giving her amino acids, L-arginine. It's actually to be, it's open, it's experimental. Nobody knows for sure. Some people even tried PRP,
PRP, yeah.
PRP in the subendometrial area. Some people just inject into the uterus, and it's difficult actually. Ovarian function also, as you said, could have been affected.
So
it's individualized.
the
There's nothing like a
recommendations
blanket
that,
rule in a difficult case.
yeah, we can go for many of the treatment which is conservative. There is no 100% results with any of these treatments. So we can try with all the hormonal treatment by estrogen and the GnRH agonist along with the aspirin. I don't think that everybody is using low dose aspirin. Any of the panelists, you are using this?
No.
Yeah, I'm using aspirin.
Yes. So for how many months? There is any specific recommendation?
Ma'am, when we are planning for the embryo transfer, at that time we used to give the aspirin, ecoaspirin 75 milligram.
Okay.
Yeah.
And what about sildenafil?
Yeah, if we find if we are planning for ET, and if we are if we are finding like ET less than 7 or 6 mm on the day 10, then I used to put the patient in sildenafil as well, 25 milligram PV. So it gives a good like endometrium.
In some patients,
about CSF, granulocyte CSF.
I have tried, it's experimental. Another thing which is new that doctors have tried is 1 to 2 units of growth hormone, subcutaneous, for the first 14 days while the patient is on estrogen. So this is again, different types of things have been tried. Do a fresh IVF collection, and before doing the embryo transfer in the frozen transfer, we can try a low dose growth hormone, which I just tried on one patient so far. But yeah, everything is individualized counseling to the patient. She
Yeah.
needs to know about the pros and cons and then proceed.
Okay. Any other panelist? Any take-home message regarding the management of this case, thin endometrium?
Dr. Sangeeta, what is your take on doing metroplasty, lateral metroplasty in these cases where we have thin endometrium and poor vascularity, not the dead vascularity, but the poor vascularity? I mean, have you seen any patient, with thin endometrium doing lateral metroplasty and then starting them on
So if the
estrogen or
uterus is T-shaped uterus, if the cavity, the volume is small, then we can go for metroplasty. But here the endometrium is defective. The zone is impaired. The junctional flow is impaired. So will the metroplasty help?
That's what I'm asking you. What is your take on that? Because many a times, once you cut deep down to the basal layer and all, and then you start giving this GCSF and the rest of the things, that sandwich cocktail, which we say. So, they, there are papers which say that, this can stimulate that the growth factors which are there.
Yeah.
They can, it is like, putting up the areas where all this can go in and then can fit and then sometime, can really give you an endo. See,
So
because these,
yeah, please.
so all this, what I'm saying is, it's because yes, everyone else agree. It is these all are treatments which really don't have a lot of evidence base. These are few studies which are being done, and on that basis of that, we give a treatment. So probably,
basically in this patient, we started with the estrogen, 2 milligram, and along with the progesterone for 3 months, and we also give aspirin and sildenafil in this patient from day 15 to day 25. And after 3 months of treatment, conservative only, patient have a pregnancy. So
Did her embryo improved, or it is on the very same endometrium she got the pregnancy?
the embryo improved after 3 months.
Endometrium thickness
Yeah,
improved.
yeah,
So
yeah.
you said you did
Improved.
priming for 3 months, you giving
Yes,
all this.
in her
And
case.
then
Yes.
in her case, and then she conceived spontaneously?
Yeah, spontaneously.
And her cycles became regular. She had those delayed cycles or whatever irregular.
Yeah, yeah. Her cycles after ATT treatment, it becomes regular. So after 6 months, she came to us with the persistent infertility, and then we have seen that her endometrium was very poor, and then we done the conservative management. She was a young patient, 26 years old. So there is
Yes.
nothing to jump on to IVF or any other treatment. So we counseled her properly, and then we gave this conservative treatment, and the
What
patient
was the
conceived.
dose of estrogen?
Ma'am, 2 milligram, 2 milligram twice daily.
Really?
Yeah, 2
That
milligram twice daily.
I think minimum TDS, or possibly 2 tab TDS should be given.
So what others says, because I have used in this patient 2 milligram twice daily, and it is
2
followed by
milligram
the registrar.
twice a day is a very low dose. If you
Ma'am,
want to
I'm
treat
using Estrobet 2 milligram TDS, as Anuradha madam is telling. Yeah, that like
Actually, ma'am, when
Okay.
it is, we are thinking that it is a thin endo and it is a case of chronic endometritis, then in that case, definitely the maximum dose which is given is 12, 2 milligram, 2 BDTDs, in fact. That is what 4 milligram TDS
May
is.
I add one thing? Sometimes giving
Yeah.
estrogen tablet vaginally, it also helps. It gives good
Yeah.
results.
Okay.
Instead of any high rate gives good results.
Patients for the vaginal estrogen?
Is there any recommendation, madam? Are there any such? Because I have not found it. What should be the exact dose of the estrogen in case of thin endometrium? It is 2 mg BD or TDS it has written, but
It
exactly
is
it is
not
no
fixed dose, na? We give according to the TVS finding.
Yes, it is
Okay.
according to the
increasing or not.
Endometrium was 6 millimeter.
Can I add one point?
Yes, sir.
Not all vaginal preparations are good. Only
Yes.
those who doesn't have a capsule or which dissolve easily has to be given vaginally. As Dr. Anu told, those tablets are really found to be useful in resistant cases because the absorption is better and the local action is better in resistant patients to give vaginally a dissolvable estrogen tablet. That can be given up to 4 milligram TID we can give.
Okay.
Usually we will give 2 milligram BD or 4 milligram BD.
Sir, is there any maximum dose? Like 4 milligram TDS will be like 12 milligram per day.
10
Is it?
milligram is the cutoff which is being given in most of the studies, and the evidence says 12 milligram is the dose. But then
Actually, it
there
will
is one
depend
study
which-
by. Yes, ma'am, please. Ma'am, please
Yeah.
go ahead.
Actually, it depends in which case are you giving. It is
Yes.
if it is an IVF cycle, then
Yeah.
high dose is recommended. But if it is a natural cycle, then after the dominant follicle has occurred, then you start 2 milligram TDS. Because if you will give it more, it will suppress the ovulation.
yeah.
So we have to be very much clear which type of person we are treating for infertility or for IVF. So these two are different.
Absolutely right.
Yes, ma'am. And
So
if the
generally, when
like
we are planning for conception and we are going for ovulation induction, madam, then after the formation of the dominant follicle, from day 8 of the cycle, generally we get the
Day
dominant
10
follicle,
you will
then we
say.
start the
Day
estrogen.
10.
Yes.
It will be
Yes.
better from day 10.
Day
Yes.
10.
And if you have given a clomipure,
Yeah.
then already it will be suppressed. Then you have to wait for day 12. But if you have given letrozole, then
Yes.
you can go for day 10. So we have to see what is the HMG. Again, it is day 10. But for clomipure, it is day 12. Because till day 12, it will be 6 mm otherwise also. So we should not call that thin endometrium because of the suppressed effect of the clomipure.
Okay.
So
But
that
in
is
these
very
patients, during first 3 months, we didn't plan for any ovulation induction. Just we are concerned about priming the endometrium, increasing the thickness. So we started on the day 1 itself.
But you
so
are
just like
asking her to come and seeing her endometrium. So if you have to see the endometrium actually, then you have to do a follicular monitoring. What is her natural cycle is? How which day? What is the not only the thickness? You have to see the zone flow.
Yes,
Zone
of
1,
course,
2,
madam.
3.
Vascularity.
So you
in
have
1
to go
month, I don't think
according
that
to
patient
Usha
will
Labem
respond.
criteria. So you see spontaneous ovulation, you see spontaneous endometrium, You want to watch, it's okay, don't give any drug. But nowadays, patient will not come costly affair. So better you go for induction ovulation and timed intercourse or IUI, whatever.
Yeah. So it was explained to the patient, and the patient conceived after that only. The conservative management.
Ma'am, sorry to interrupt. I have one question. Ma'am, in this, after 3 months, you got a positive result, but suppose the patient does not give a positive result, she does not conceive. So for how many cycles can we give this much dose of estrogen to a patient considering the risk of endometrial carcinoma?
Why? You are thinking that there will be risk of endometrial carcinoma?
And because of oral estrogen?
Well, 3 months shouldn't cause really, because
So
people
after
sometimes
What is the
undergo FET.
maximum till what we can give?
It is a low dose. It is not in a high dose, and there's no high risk factors also. Okay.
Endometrium is not proliferated. Then there is no carcinoma.
We give people undergo FET, and if 12 milligram oral they don't respond, we even go for the percutaneous or even patches and other things. So for FETs, people undergo up to 6 cycles at least. So if the woman is not obese, older, or diabetic, her risk would be less.
Yes.
Okay, thank you.
So this is my last case, and that is she is a case of 32 years female with the RPL, recurrent pregnancy loss. There are 2 abortions, and she is married for 5 years with secondary infertility. Her menstrual cycles was normal, and she has 2 abortions, one at 2.5 months and one at 1 month, which is followed by DNC. So in her case, how you plan for further management?
We'll offer investigations for recurrent pregnancy loss because she's 32, even though some Royal College and others say 3 miscarriages.
Yeah.
2, I think we should offer.
Start investigating.
We should start investigating.
32 years, seeing her
In her age and 5 years.
So we need to offer her for the ovarian reserve test and all the investigations for RPL. So investigated for RPL, and it was normal. LA-ACLA beta-2 glycoprotein was normal, and her FSH was on the higher side. It was around 13, and AMH is 0.5. Okay.
She has got POR, poor ovarian reserve. That means.
Yeah. So we advise her for lapro and hysteroscopy. So on lapro and hysteroscopy, her uterus was congested with bilateral hydrosalpinx, as you can see, and the tubes were patent. Okay, on dye test. And in hysteroscopy, the dense adhesions were present. It was adhesolysis was done. Gene export was negative, and histopathological examination comes as a chronic endometritis. So now, how will you advise?
The appearance of the
treatment in her case?
Ma'am, we have 3 positive findings as her on laparoscopy. She's having bilateral hydrosalpinx, 1 positive findings, adhesions, another positive finding. On histopathology, it is chronic endometritis.
Yeah.
It's possibly bacterial usually, so I agree.
So we can start her on the.
So tubercular, basically genital tuberculosis causing bacteria is a possibly biliary. So it's very difficult to catch. So in this case, with the kind of picture, we can start her ADT. Okay. So we have started on her ADT, and she has a hydrosalpinx. So what you will do? Whether you drain the hydrosalpinx, you will send the fluid for the cytology, or whether because she is a case of 32 years, her AMH is 0.5.
See, it will be difficult for her to conceive normally because what is the AFC for her in both the ovaries?
Central follicle is lower side. It is around 4 or 5.
4 or 5 is okay.
It depends on her lifestyle, and sometimes after ATT, her AMH can improve. In some cases, it has happened because it does suppress and have an effect on the ovaries.
Like little bit, improvement in it can be there. Advice for
lifestyle advice along with ATT.
Yes, she can be the candidate.
Lifestyle and multivitamins to slow down ovarian aging.
So the most important thing, as you said, that if there's a hydrosalpinx, don't need to puncture because the tubes are patent. So when you start the ATT treatment, the tubes will become normal. Okay.
Yes.
And I can't tell about the physiology of the tube, but grossly it becomes normal and atomically it will be
Yes.
normal. So what the recommendation says that if the tubes are patent and if the endometrium is normal, if you are doing the TBS with the Doppler and the flow is good, we can still try for natural conception or ovulation induction, not for a long time,
3 to
for
6
2 or 3 times, yes, but with proper counseling. If the tubes are blocked, the normal endometrium is there, yes, he is a candidate for IVF and embryo transfer, but yes, the success rate is 25%, not good. And if the tubes are blocked and the receptive endometrium is not there, if there is more than grade 3 adhesion in hysteroscopy, then she is advised for gestational surrogacy. And if the ovarian results poor, then the adoption is advised. So this is the guideline when to start the IVF or when to advise a patient for gestational surrogacy, because IVF results are very much compromised in these patients of tuberculosis. So can somebody tell
Sangeeta,
me
can I
if one
interrupt,
is,
please?
yeah.
Can I just ask you, because it's quite contentious here, where you said that sometimes, you know, there'll be people who, you know, in such a picture, you're leaving the tubes and you're leaving the hydrosalpinges. So whether you should take it out and then give them the ATT, because that's another contentious area that can be in some studies, they've shown it to be a nidus of infection which persists. As you said, we don't know whether it will resolve or not. Either we have to be clear that we're going to do another lapro, look at the status, because if you're going to do an IVF with hydrosalpinges, you anyway in a catch-22, your success rate is going to go down.
Yeah, definitely.
So you have to be very clear in how you plan. And not everybody can afford repeated laparoscopies. So I think for all of us as fertility specialists to make that decision, when you put the scope in and you're seeing gross hydrosalpinges, whether you're going to remove it, take it out, or you're going to clip it. So I think that is something,
Should
again,
I
we have
give
to
answer?
individualize.
Should I
Yes,
say my
ma'am.
opinion?
Yes, ma'am.
Oh,
Yes,
please,
ma'am.
ma'am.
Yes, ma'am.
Definitely.
Please.
Definitely.
Actually, I have done it to quite two, 3 times. I had this situation. So what I did, I just asked the husband to come inside the theater.
Yeah, and show the
And I have explained everything. Look, this is the situation. We don't know what will be the future. This may open, this may not open. So if it is not open, if it will remain like this hydrosalpinx, then for IVF we have to remove it or at least clip
Yes.
it, whatever.
clipping. Yeah.
So he said, Madam, don't do anything. Let us complete the course of ATT and later on we will see what will. So this is my counseling for such cases. I explained to the husband and just give them all the thing, because we don't know what will happen. Many of them will become pregnant, many of them will not. So we don't know the future. So it is best to counsel the husband, and accordingly, suppose she is getting 35 and she is with low AMH, then 35 to improve AMH is poor. Likely she will go for IVF. Then I will like that it will be better counsel the husband to get it removed and then go for IVF. But if she's 32, she's 30, she's even younger, then better we can counsel the husband. And if he says, if he is in a hurry, then better you take it out. But we have to all discuss so
Yeah.
that we will not have medical legal issues.
Yes, ma'am. It is very much
Definitely.
important. You have clearly mentioned that
Counseling.
counseling has a great role. Because
Ma'am, I
if
just
the
want to ask.
hydrosalpinx, and even if after ADT it becomes normal, there is chance of ectopic pregnancy. So
Yes.
the counseling should be there. And if the patient wants that, yes, she will go for IVF, then we should have to go for the clipping at the same stage, because we all know that the gender of the embryo with the fluid, toxic fluid. So in
Ma'am,
our case, yeah.
Ma'am, I just want to ask one question. Before proceeding for diagnostic laparoscopy for this type of patient, should we take the pre-informed consent when the patient, before giving anesthesia to the patient, or we can just do it by taking the husband consent intraoperatively?
No. Always your husband cannot give consent.
And the husband,
Always
because
patient's consent.
because otherwise
Patient.
patient will fight in the end ki you why
No,
have you done
he
it without
cannot
her?
take this
Exactly.
decision on OT.
And
Please.
Because
actually, she might even leave
Actually,
the
in our,
husband if she doesn't fall pregnant.
exactly.
actually in our,
Anything is possible. Don't do anything without telling the woman.
Yes,
actually
ma'am.
there is
Because
a key take-home message which I really want to tell. In our country, maximum time, when the consent comes, it is being said कि घर वालों को बता दो. Take it from the घर वाlas. So this is a very important point that everyone has said. Consent of the patient is very important.
Yeah,
And then what
100%.
madam said, 100% consent is very important. And then, we also see so many patients, we go inside thinking of something else. She has a case of secondary infertility, seeing a massive, tuberculosis, tubercles and so much of inflammation. Just call the family member, as madam said, show it to them, and we tell them we are going to give you the treatment. We will again relook after 6 months. That has to be said, as what Tanya said. It has to be done in these patients, because you don't know. Sometimes some patients respond so beautifully that they come conceive naturally, and some of them, they might have that hydrosalpinx, or maybe because sometimes you are not even able to see what is there inside. So after giving 6 months of treatment, it is something which has to be done and has to be told. And I have seen in my practice, when I show this to the husband, that see, this is the state. Agar isme hum log kuch bhi karenge, it might become fulminant. So we will stop our treatment now. We'll give her you 6 months of treatment, and again we are going to do it. Mostly 95% of them agree, because they see it, so they agree to it. So relook has laprohisto. Once you think it is ATT, I think it's really mandatory even to give her the treatment later on, because IVF is a very expensive affair.
Yes.
Yes, ma'am.
Yes.
We really
Agreed,
have to.
ma'am. Thank you.
Many times doing all that will really help. So that is why I think JB Sharma sir, and even if you talk about Dr. Abha Majumdar ma'am, Alka Kapnali ma'am, Anuradha madam, laprohisto plays such a key role when it comes to genital
ma'am.
tuberculosis.
So I just want to ask the IVF specialist over here, because when you are referring these patients for IVF, a case of tuberculosis, so what are the results? Is the results similar to the other patient without the TB? How you
That's
counsel
what
these patients?
Dr. Sangeeta, that's what I told. It is very difficult to tell for every patient, because every patient will react differently with the ATT treatment. Many of them, even if they are in advanced stage, you start them on ATT and things really vanishes. It may be because of they have a good immunity, or maybe whatever it is,
Basal
and then
layer
they
is not
conceive.
so much damaged. Yeah.
Yes,
Yeah.
yes. But
Depends on
yes,
depends on the
It's
extent.
endometrial. I think
Extent
Ekita
of
spoke very well.
endometrium is involved
how
for
much is
every
the end of
class.
for anything to get a bad result in IVF? That is what one of the studies also, when I showed, as such, they really have a bit poorer result than the IVF patients.
Yeah.
But
That's
if the endometrium is okay, then you can really think of a somehow comparative result in both of them. What they have said, clinical pregnancy might not be same, but once they conceive, they will have the similar result. Okay. That is what they say. Most of the studies say. So it is such an enigma. Give the ATT and see how wonder it does. It does such a good wonder in meningitis patients. यार जो कॉमा में पड़े हुए हैं उनको जैसे ही शुरू करते हो 15 दिन 1 महीने के बाद होश में आ जाते हैं. तो even we expect the same for our infertile couple also. Give them a
but
chance
the
of getting a
counseling here
good
is
ATT.
very much important, because
Yes,
IVF is
very much
very
important.
costly, and the patient will think that yes, with IVF they will get pregnant. Because in these patients I referred for IVF, and even 2 cycles of IVF, the patient didn't conceive, and she come back to me.
So probably the endometrium factor is quite important, and if it is good, then yes, we will not be blaming it on TB. We do have,
There are
a
many
success rate,
factors,
cumulative
but
success rate of 65% after 2 cycles. So we have to really think of everything, saying whether it is not conceiving because of taking treatment with TB and not getting better, or whether it is because it is like that. Many patients who don't have TB also in 2 cycles, they might not be conceiving. What is the success rate with the 2 cycles? Cumulative is 65 to 75%. So still 25% don't conceive. So really, it's a very sensitive matter to decide what is the factor which is responsible. That's
One
what,
more point, Ekika, as you said in your lecture, treatment of latent GTB, it helps, and it helps in a beautiful way. Patient conceives after giving treatment.
Yeah. So that's why you have to catch them with a strong suspicion, with the proper history taking, and yes, your diagnosis. Very much important. So Dr. Ekika and any panelist who is an IVF practitioner, what are the options for poor ovarian reserve? Because most of the patient doesn't want the donor egg. Yeah. So in your practice, these are the few options. What you will use, and what is your take home message for these patients? The
I
IVF
think she clearly said they're all experimental. The rest,
Yes,
Ekika
they're
can
all
talk. I mean, we have enough evidence now on PRP, stem cells. I mean, if you talk ovarian rejuvenation, are you talking of, the mitochondrials or whatever you can think of? Each patient responds differently. None of them are standard. You give them the counseling and you see what works for them. but really there is no magic treatment for POR. Again, if she's 25 with POR, it's different. If she's 41 with POR, it's different.
Yeah.
So I think
It
Ekika's key
depends
point
upon
was
the
very
age,
clear.
yeah, other factors. Thank you
And
so
the
much.
other thing, if
And
the
then
woman
all
is
these
willing,
things, yeah, and
if the
all these
woman is
things,
willing, sorry.
yes, probably. I'm sorry, please continue. It's
No,
absolutely
if
right
the
that
woman
woman
is
has to
willing,
do
we
it.
can do like tandem cycles. We can do duo stim or try to accumulate certain eggs and then do IVF all at once. It depends a lot on counseling, how much the patient can afford. And these are all experimental. The patient needs to know that there's no one shot. This is the solution for her problem.
And once a patient, Sangeeta, once a patient comes to us, it's not only the treatment, it is their pocket and finance also, which
Yes,
really
of
in India
course.
we have to keep in mind.
Yes.
So this PRP is okay. Still, it is being done at many places, then you can really adjust the price. But when it comes to autologous stem cells and the ovarian manipulation, I am not sure. I mean, if I talk to, I'm telling you a real truthful scenario, nothing with the evidence and the and whatever the recommendations. When a patient comes with POR, she comes from a place, she has already shown so many people, she is already being drained out of her money. And you explain her everything and you ask her what she wants. I think, I mean, in the areas where we belong, 70 to 80% will say, Madam, please take donor oocyte. I cannot afford all this. So I don't know. I mean, how to, say that we are working on it. Sangeeta, BHU, I mean, the type of gender which you cater, do you really think they can go for all these experiment? They just want a baby.
No, it
So
is
really,
just your opinion, IVF practitioners, because the PRP,
that's
there
what
are
even
lot of work which has been done. I am asking just your message regarding other options, whether you are doing in a good center like Mumbai or Delhi, they are doing it or not. It's just for an opinion.
Sangeeta, even stem cell is very expensive. So I think we need to know PRP is still why it's far more widespread. It's
Yeah,
easier
that's
to
why I
do, as
started
Ektika
the
said.
talk.
It's
Yeah.
easier to do. You can do it in your labs. There are huge issues with doing stem cells. You've got to have a center which is accredited. You've got to have a blood bank.
Yeah.
There are the legal issues with which setup
With the
can
stem
do
cells.
stem cells or not. And it's not easy. It is painful. It is expensive. So if someone, as you said, even in a center like Delhi, I mean, if you were to compare head to head between stem cells and PRP, I think we do far more PRPs than we do stem cells. And again, in my own practice, is it the magic pill? No, it's not. When the patient is so frustrated, you do anything. Like Shri just said, you could do back to back 4 cycles and you can probably gain as much as you will gain with doing a PRP, doing a dual stim. You can do everything you want. But I think Ekika, I would agree. At the end of the day, after doing
So there's
even
no
1 or 2
single
cycles, they come
method.
back and say, "Bhaiya, bacha chahiye." So
Bacha chahiye.
that's the key point.
This is the real
Okay.
scenario which we really face everywhere in our country. It is not as similar as in Western countries. So let's
Yes.
face it,
And
what
actually,
we
very true. Yes. Even after doing PRP, we are not sure we'll get oocytes or not. Even doing PRP is difficult. Technically, it is difficult.
Yes.
Sometimes the ovaries are higher for patient is obese. It is not that easy.
Okay.
Ma'am,
I
it
think
depends
patient
upon,
wants baby.
like it depends upon the thinking of the patient, because I have done my fellowship from craft in Kerala. So there the people were very adamant about using their own eggs. But when now I'm practicing in North, and that means in Haryana, the belt is like that. They don't want to spend more. They just want to go for the donor, because they say that हमें तो success चाहिए, हमें अपना use हो या किसी और का, that doesn't matter to them. Actually, they want the success. So they are more pro towards the donor rather than stem cell and PRP and all these regimens. Actually, what I'm feeling right now.
Yeah, very true.
Yeah.
The practice doesn't allow this.
Yeah, that's what. Yeah.
Thank you so much for your expert opinions.
Thank
The
you.
last is about gestational surrogacy. So when you will advise gestational surrogacy in a tuberculosis patient? Any of one of the panelists?
When the endometrium is thin beyond repair,
damage,
like it's, when we are not going to get it. Pregnancies have been reported in endometrium as thin as even 5 mm,
5
but
mm, yes.
that will be drained out, and you can't keep on trying when you know it's not good enough, especially when there is fluid in the endometrium, despite whatever we have done, clipping the tubes and everything. I think we need to draw, but it's very expensive. And,
Yes.
and I think according to the new ART rules, they can probably bring someone they know also, because it's supposed to be altruistic.
Yes. Surrogacy also is very difficult these days.
There are only few options for advising gestational surrogacy when there's a severe intrauterine adhesions, as you have said, which is not abnormal for hysteroscopic adiosolysis. There's atrophy of the basal layer of endometrium not responding to any hormonal treatment. ET is less than 7 millimeter in spite of the estrogen supplementation with high resistant subendometrial blood flow in proliferative phase in the repeated cycles and dense pelvic adhesions causing repeated IVF failure and multi-drug resistant genital tuberculosis. So with this, I think I should end up this discussion because I think there are many cases, but I think it is 10 o'clock. And Dr. Anu, I think I will stop here because there are many discussions and we have a good take-home message from all the panelists and all the experts over here. So despite the availability of the various diagnostic techniques, diagnostic dilemma will exist. There will be disparity of the opinion for all the patient, but your treatment should be individualized. As Dr. Ekika said, they are depending upon the age of the patient, the economic status of the patient, how many years of infertility, the ovarian reserve, and yes, the counseling. So with this, I will end up this panel discussion. Thank you all the panelists for your involvement and thank you all the experts, Dr. Anuradha Khanna ma'am, and thank you Dr. Anu for giving me the opportunity.
Thank you. Thank you so
Thanks a
much,
lot.
ma'am.
Thank you so much, ma'am.
Thank
We
you.
really enjoyed the panel. It was a live, really interesting discussion, one-on-one panel.
And very
We
thought-provoking.
had all the exemplary cases from our department. Lovely panel. Thank you so
Big
much, ma'am.
congratulations, Dr. Sangeeta. You had very remarkable, memorable presentation, discussion. Everyone, all my whole noun panelists are very thoroughly brained and very, very nice and beautiful. So,
Thank you,
big
ma'am.
congratulations.
Thank
to
you,
all.
ma'am. Your
Thank you, ma'am.
opinion always guides us. Thank you so much.
Thank you, ma'am.
Thank you.
Thank you, Dr.
Thank you.
Sangeeta.
Thank you.
Thank you.
Thank you,
Thank
Dr.
you, Dr.
Sangeeta and the
Sangeeta.
panel
Fantastic
members.
panel.
Thank you, sir.
And thank you, the chairpersons. And Radha madam, thank you for being here right from the beginning.
Yeah, this is a subject very close to my heart, both genital tuberculosis and endometriosis, because that is still an enigma, both of them. Very difficult to treat, but
Ma'am,
once the patient.
yes, we thought about, like, whenever we see the patient and we think about GTB, like, you always come into my thoughts. Madam would have
Thank
told
you.
this.
Thank
Madam
you.
should have done this.
So even
you
Dr.
so
Anu, I really had a thorough discussion with madam because when I was doing, there was so bit confusion. So I called up madam. Ma'am, please guide me in your experience. So you are a wonderful teacher, ma'am. Even till
Madam
date,
is encyclopedia, Ekika.
absolutely a gem.
Actually, we call her
I just
encyclopedia.
helped her. Ekika, I said, Ekika, see all these aspects. And Ekika has done a wonderful job. She has
Thank you,
all
ma'am.
taken out such a good, all presentations, China's, Indians, Dr. J.B. Sharma's. Really, it is remarkable. So good. Congratulations again. To you.
Thank you, madam.
Thank you, ma'am.
Thank you very much. Thank you, ma'am. Really enjoyed. Good night. Thank you.
Good night.
Bye-bye.
Thank you,
Thanks a
ma'am.
lot.
Thank you, Anu.
Thank you.
Thank you,
Dr. Anu,
Anu.
can you
Thank you.
conclude?
Thank you all
And
the
thank you,
experts
Dr. Fessi,
for
for
being
including me
here
in
tonight.
this wonderful panel. It's a wonderful whole scenario and whole teaching where we learned a lot right from the panel and from sir. And Sangeeta, it was wonderful cases. Really a food for
It is a
thought
real
for all
case,
of
Dr.
us.
Ekika, and
And
yes.
the way it's being taken care, this is what is required. When we talk about all this, this is what is required. I mean, how
Because
the
actually,
clinic.
Dr. Ekika, we do manage depending upon our infrastructure.
Yes,
So
that's
there are
true.
some
That's
glitches, yeah.
Yes, yes.
That's what panel member audience want to know, rather than in your context, how different people manage differently according to their resources and the settings. That will be the real use. Then only it will be really useful for the viewers.
Thank
Thank
you,
you once,
Dr. Lewis.
Dr. Anu. I
Thank you.
think
Thank
can
you.
you conclude, Anu?
Yeah, so it was a wonderful session. Dr. J.B. Sharma's talk, Dr. Ekika's talk, and the panel by Dr. Sangeeta, and expert comments from our experts, Dr. Radha Khanna madam. So it was wonderful. So thank you. Thank you.
मैंने भी बहुत कुछ learn किया, no? Why I'm here up till now? Because I'm still a student, you know. I'm still a student.
Yes, ma'am.
That's what we all have to learn
Love,
from ma'am.
love
Yeah,
and respect your energy, ma'am. Absolutely.
Yes.
I heard that you had an operation done 4-5 days back. Just love your energy. It's so commendable that we should all learn from you.
Thank you so much.
How are you, ma'am? I'm sorry.
Okay, good night.
Good night. Good night. I think we expect for the next month's edition, as Dr. Anu was telling, most probably we'll be doing on 19th, August
Yes.
19th. Every month we are having. And thank you, UNS team, Dr. Nagul.
Thank you, sir.
Nagul,
Thank you very much.
can you conclude?
Yeah. Thank you. I must thank you all the expert for being here tonight for this 12th series of our ISAR UNS Catalyst webinar. Your presence truly made special. Lot of insights regarding genital gorge and infertility. And today we had an impressive participation. That participation is around 559 that delegate they attended our webinar. And I would like to extend my heartful gratitude to our distinguished speaker, chairperson, moderators, panelists, as well as today chief guest and guest of honor. Special thanks goes to Dr. Amit Patki, Dr. Asha Bakshi, Dr. Anu, Dr. Fesi. Thanks for your support, and looking forward many more engagements. Thank you. Thank you all.
One last thing, the previous episodes are there in the ISAR website, and if you log in the same link, you can see that if somebody has not seen live, they can also see it. So the same link they can use tomorrow in coming days also, so that you can see it if you have missed it, or if you want to hear some points again, you can log into the same link. Thank you once again, UNS team. Thank you. Good night.
Thank you, Anu ma'am. Thank you,
Thank
Pesi
you.
sir, for
Anu
inviting
ma'am.
me.
Thank you, Pesi sir.
Thank you so much. Thank you. Thank you, ma'am.
Okay,
Thank
good
you,
night,
sir.
ma'am.
Thank
Arik's team, please stop the recording.